learned speaker from Pune, Hyderabad. We are very much thankful. I'm thankful to Dr. K.N. Chandan Kumar, VINIT SHAH, NEERAJ SARAF and Mithun Sharma. I think we will get a feast of education. We will enjoy, and the topics are really very good. Please, over to MOC.
Good morning, everyone. Let's begin with our scientific session with first topic on introduction of vitamin E and NAFLD. So for that, we have privilege to have Dr. SAUMIN SHAH. As we know him very well, so he doesn't need any introduction. He is a great academician and very enthusiastic personality. I will request Dr. SAUMIN SHAH to welcome all and to throw some lights on this topic.
Good morning. I think Gujarat Hospital, when we started in 2018, we used to organize such type of conference yearly, but because of COVID. Yeah, sir, in my lecture there is no chairperson because I am a part of APS family. Okay, so I am not a faculty. So when I planned this conference, and I since last few years, since the years of residency, what I thinking why we are organizing this conference. Okay, so medical conference, there is a beautiful paper by Dr. Sudeep Mishra. Is medical conference has role to play in now age? It is in the 2016 pre-COVID era paper, and it is a cardiologist. It is written by cardiologist. I welcome Dr. Chandan is here. Okay, so it is a paper by cardiologist, and he beautifully analyzed why we should attend a physical conference. Okay, so this is a data of 2015 cardiology conference, because they include this data because there is an intervention as well as the clinical job. Okay, so 53 major conferences which attended by, they have cut off of 300 delegates. If they have been attended by more than 300 delegates, Dr. Mithun is also there. Okay, so if they are attended by more than 300 delegates, it considered as a major conference. 53 major conference occurs in entire India in a year, and 150 minor conference, less than 300 delegate is minor, just like our conference, 150. The total number is 200. Okay, and this is a physical conference. So, but they have observed that few peoples are coming back to back. Okay, and the young guns and resident doctors are missing. So why this is so? So we have to introspect ourselves, why this is so? Because even in this conference, I have personally invited resident doctors, okay, to infuse a culture of education rather than a come, meet and eat. It is a continuous medical education. It is required to sharpen your skill. But you see, till at the time, I think hardly 2 or 3 resident doctors are there. Okay, so why do we attend medical conference? There are lots of other media, webinar, podcast, YouTube. Okay, is there any need? So there are plenty of the purpose. Few purposes are, we can meet old friends. Okay, we can do professional networking. We can project ourselves. That's you see that I have done this thing, I have done this thing by the speakers or by a chairperson or by a faculty. You can ask question and you can see, you can show that I know this thing. Okay, then to spend a quality time with family entertainment, I really doubt this intention. Okay, I personally feel you need to be a very balanced person when you go outside with your family to attend conference academically as well as to enjoy with the family. This is practically impossible for me. Okay, so if you cut off everything outside your practice and focus on the medical education, then and then the CME is going to be more fruitful. Sometimes it is just we attend to maintain relationship. Okay. Sometimes it is just a formality. Oh, I have to attend this. It's just a formal event. And to update on the recent advances and develop a new skill. Now, I personally feel that this, I have kept the last particularly for the resident doctor. In 2018, we have arranged the major conference. In 2019, we have arranged the conference. Before COVID, we have a monthly resident meet. But I feel that we are not able to, what we call the enhance or infuse or make them enthusiastic about the learning purpose. So, why do we organize conference? For myself or any organization body, it is just to promote education. It's a type of that we can meet each other, we can know each other. But more important, it is improved your management skill. Okay. And as well as to project certain things. Now there are many great ways to learn, but till we have to attend a physical conference. So physical conference has its own advantage. But you just cut off your outside practice and focus on the lecture. You just note down 2 or 3 things in entire CME and try to implement in your practice. It may not be directly beneficial. Sometimes I have seen people come, people go, and CME is over. But suppose there is I personally feel that suppose there is a half day CME, at least you point out 2 points in half day CME that you are going to implement in your patients and you see the result. That will be beneficial if you are spending 4 or 5 precious hours of your Sunday. Okay. For me, it is to meet a professional idols. Okay, I will meet Dr. Mithun, Dr. Chandan, Dr. Vinit. So it will give me a tremendous amount of the energy because they are so much learned. Okay, they have particular protocol. We can discuss. So it will keep me motivated to do a good practice. Okay, if there is a certain new procedure, we can introduce in the workshop. And this is from the breakout of the psychological zone. Suppose you attend a webinar. Suppose we do this online thing. Okay, and you mentally prepared that I will attend this online. But how many of you are able to attend this online? So you have to break your comfort zone. You have to remain focused. If you are spending 5 precious hours in a Sunday, then at least you have to keep 2 or 3 points that will improve your practice and that will beneficial in each way. It will make you sharp. It will also help financially in the long run, in patient management. Okay, and it is for the meet like-minded people, okay, who have similar thought process. So there are plenty of the advantage of attending a physical conference, but my personal advice, once you come here, you have to cut off at least for 4 hours that we are going to a school and we have to attend this. So how can we improve ourselves? We have to change our mindset. Okay, this is not just to come, meet and eat. Specific CME and focus CME is more important. This is a relatively till a week CME. That's all hepatology. Next time we are planning even a specific, this is about the acute liver failure. Even more specific, this is about the hepatic encephalopathy, and this may be a more focused group and it will be a more learning. Okay. Educate the resident doctor, we are trying since 4 years and hope it will improve. Organizer must have some specific vision. Each and every organizer, they have their own vision. It must be a healthy, transparent relationship with me, you and sponsor. And most important, the maximum time utilization. Okay, few are coming from Navsari, few have come from Vapi, few have come from Selvas. Okay, so if we are going to reduce formalities, I think that should not be done. Then and then your time can be utilized. So last, that is make it paid. That is my personal opinion. Okay, you have to pay certain, because then I think it will what we call the psychological factor. If you pay, you will definitely give attention. And this time, okay. So I have not kept my introduction. No formality, no felicitation from Gujarat Hospital team. Okay, even for chairperson, I am giving thanks and felicitation right now. Okay, So we can just spare that time, and the speaker across the country is here, you can interact more. So that's why we keep a lecture of 30 minutes rather than 20 minutes. What says that 20 minutes is an attention span, but we keep it deliberately 30 minutes and 10 minutes of interactive discussion. Okay, and I am going to reduce my lecture right now. So if you want to interact more, you can interact. Okay. So this is some manipulation. There is no flowers. Everybody knows what happens to the bouquet at the end of conference. Okay. No felicitation for the chairperson or organization, nothing. No introduction of myself. Try to keep discussion academics. What I have seen, particularly in the workshop, okay, what is the cost of this procedure? Oh, our patient is not affording. You see, this is practical problem. That is better discussed amongst your colleague rather than the faculty, because the working environment of the AIG or global hospital or RELA institutes is much different than your nursing home or Gujarat Hospital. Okay, so if patient is not able to pay, how can you manipulate the treatment? That we can discuss among yourself. But you try to remain focused in this CME. Then we try to I am going to reduce lecture for myself. No vote of thanks from my side. Okay, I thanks all APS member, Tarun Bhai, Ramesh sir, which helped me immensely. I also thanks about people. Okay, and my Gujarat Hospital team. And I do it deep inside my heart, but we will reduce this formality. So our next CME, okay, that will be my agenda. That is a group of 20 people. It is a paid learning process. And resident doctors and the young guns will be of our focus. There will be no pharma support in that CME. That will be entirely supported by myself. Okay, one module for the screening purpose. For 20, how many is really interested? Then second module, we will filter that. Out of 20, 10. And out of that, we only choose one guy who really learn this procedure and who can impact the society. And particularly, our motto is to see a guy from the interior. Okay, just like AWA or something like that, that the facility will be available there. And whatever the funds collected by this group of 20 will be utilized on the same day or same week in the patients, and patients' detail will be giving to each and every participant with the vote of thanks. Okay, now this is just like an experiment, and we will tell you also okay, how it's going on. So let's try to understand the science. Okay, I will cut short this vitamin E part. Each and everybody knows about the vitamin E. Science is like Lord Krishna. Okay, it looks like simple from outside, but it is a very complex procedure. And there is a one last slok in the Gita. I don't know the Sanskrit, but meaning एवो था कि जितना मेरे को पता था मैंने तो सब बताया. तुम्हें जितना लेना है तुम लो. Okay, so we try to maximally utilize. Though we are Arjuns right now, and all faculties are like Lord Krishna to us. Okay, whatever we try to achieve, and we try to gain. Okay, so vitamin E in NAFLD. Now you see in NAFLD, okay, there are few processes: oxidative states, inflammation, cytokine, apoptosis, and fibrosis. So vitamin will act in the oxidative states. You see, oxidative stress is very high in NAFLD compared to the other etiology of hepatitis. Now, this is a classical OPD patient, 49-year-old gentleman, obese, BMI 28.4 kgs, diabetic, hypertensive, having a high ALT level, fibroscan is 8 kilopascal, cap value is 320, and liver biopsy is refused by the patient. This is a usual scenario because patient is asymptomatic and came for the health checkup, and you got this result and you ask for the liver biopsy, definitely patient will refuse. So what was our claim? Does vitamin E in diabetic decreases the insulin resistance? Here is the data, but it is a no. It will not affect the insulin resistance. I am not going into the data. Does vitamin E reduces the ALT level? It is a yes. It reduces the ALT level. But this is a classical trial which introduced the vitamin E into the Nash, PUNE trial in NEGM. But once you discontinue the vitamin E, once you discontinue it, then again graph is rising. This graph is rising. Once you discontinue it, again ALT is elevated. Does vitamin E improve the histology? Answer is yes, but it improves the inflammation, not on fibrosis. Okay, so hepatocyte ballooning, necroinflammatory activity has been reduced, but fibrosis remains same. This is a tonic trial which suggests that it improves the fibrosis, but in PUNE trial they says it does not improve the fibrosis. Okay. So this is very important. Does vitamin E lead to the clinically meaningful improved long-term outcome? Now this is a retrospective data that vitamin E has been used in the patient, but if you see, there are around 2/3 of the patient has a diabetes and 2/3 of the patient has a cirrhosis. PUNE trial was on the non-diabetic and non-cirrhotic patient. So this is a retrospective data. In what we missed in the retrospective data is the few objective we failed to measure because it's a retrospective analysis. But still, you see the all hepatic decompensation is less in the cirrhotic patient. So even in PUNE trial, vitamin E has been used in the non-cirrhotic. In cirrhosis, you can use it safely, and it will reduces the decompensation, as this retrospective data say, and it will also improves the transplant-free survival. Okay, there are long-term vitamin E will reduce the all-cause mortality. We know Nash is a part of a metabolic syndrome. It is not a single disease; it's an entity. So all-cause mortality by Nash, it has been reduced by vitamin E. Is vitamin E is effective even in diabetic and Nash population? Yes, it is effective. There is a RCT in type 2 diabetes mellitus. Vitamin E has been given for 18 months. So if you see, the primary outcome is reducing the NSAS, necroinflammatory activity score, okay, and it is better than the placebo in the numerical value, but not statistically significant. But vitamin E plus pioglitazone is statistically significant, but in this trial, pioglitazone has been used in 45 milligram, it's a higher dose. Okay, and the secondary outcome, it is statistically significant. Without worsening of the fibrosis, it is lead to the resolution of the inflammation. So long-term use of the vitamin E, initially it was said that the long-term mortality, long-term use will lead to the increase in the all-cause mortality, but now new 51 studies which included 246,000 subjects denied this claim. So there is no increase in the long-term mortality with vitamin E, but however there is a slight increase in the risk of the prostate cancer, but it's a definite risk, but it is a very small. So long-term side effects does not noted over a period of 6 years almost at a dose of 800 international units per day, but the sample size was very small to observe a small side effect. So in summary, vitamin E should be used in 800 international units per day. It improves the inflammation, no changes in the fibrosis, can be used in the diabetic, can be used in the cirrhotic, and can be used for the long time, because PUNE stands is only for 2 years, but you can use it up to 6 years with the safety data. So I am reducing question answer time because I am always available in Surat, but we directly go to the next speaker because we are already running little bit 5 minutes late. Okay, so I think you can more interact with them, and next we can interact with during the lunch. Thank you very much.
Thank you, Dr. SAUMIN sir. It was really interesting to know the facts about the therapeutic use of vitamin E, and I hope you are going to be the trendsetter for organizing the conferences. Thank you so much, Dr. SAUMIN bhai.
So now we'll move on to our next topic, that is pre-operative fitness in cirrhosis of liver. So I request Dr. Chandan Kumar and the chairpersons for the session. Chairpersons Dr. Vipul Bhadiadra, Dr. Rohan Jariwala, Dr. Dinesh Kanpurwala, Dr. Shailesh Jethwa, to please come on the stage. And I request Dr. Bidita to introduce the speaker.
Being a clinical nutritionist, this is really an interesting topic for me because it is, and everyone know that it is need of an hour to know about the pre-operative fitness and cirrhosis of liver patient, because we all know that there is significant discrepancy between the number of candidates and availability of the liver grafts. So to throw more light on this, we have today Dr. Chandan Kumar, who is a senior consultant and lead transplant physician at Gleneagles Global Hospital, Hyderabad. He has done his MD from Manipal University and DM in Hepatology from ILBS New Delhi. He has also received formal training in transplant hepatology at Mount Sinai Medical Center, New York, as well as King's College Hospital, UK. He has more than 50 original and review articles in international and national peer-reviewed journals. So board is all yours, Dr. Chandan Kumar. Dr. Chandan Kumar, please come on the stage. Thank you.
So, till the time laptop setup is going on, during question answer session, you can ask your practical queries also. Okay, because we have deliberately kept this a little bit lengthy. 10-15 minutes you can take. Suppose INR is 3 in pre-operatively, how many FFP should I give? Should I give or not give? So, try to make it more practical that you can implement on your practice. Okay, if INR is 1.92, it is INR more than 6, should we give a pre-operative fitness? Okay, does it really require a hepatologist? I personally feel if you know basics, you don't require hepatologist for the pre-operative fitness. You can do it your end also. Okay, but try whatever the query, you can just write down till the write down this is the practical problem I am facing. Suppose sonography suggestive of cirrhosis, but everything have fibroscan, ALT is 68, no other report. Should we go for pre-operative fitness? Because I have seen a few cases when because it's a minor procedure, SGPT has been done around 60, 67, and pre-operative fitness has been given, and after pre-operative fitness, after surgery, patient decompensate. Okay, so should we evaluate such type of patient? Because in our mind, mild transaminitis, if SGPT is 60, it's not a worrisome. SGPT is 1000, it's a worrisome. But it is not always true. SGPT 1000, it suggests a chronic event, acute event. Okay. But mild level of transaminitis, persistently 50, 60, 70, that may indicate that ongoing inflammation is going on and you don't know the duration. Okay, it may be a transient within a month, within a 2 month working, or it may be for years. Okay, so let's over to Dr. Chandan.
Thank you, Dr. SAUMIN. I'm very sorry for the technical problem because I was preparing slide till now. At the outset, first I want to thank Dr. SAUMIN and the warm hospitality of the Gujarat Hospital and the wonderful people of Surat. Thank you. So today I'm going to speak on pre-operative fitness in cirrhosis. It is a pretty tough topic because not much data is there, but I'll try to make justice as much as possible. So this is my profile. I don't have any disclosures. So before we start, I want to just give a case which we commonly see in our day-to-day practice. So this is a 45-year-old gentleman with alcohol use disorder, abstinent since 3 months, complaints of fatigue for 5 months, on evaluation diagnosed to have chronic liver disease. He was initiated on antivirals for the same. There was no history of any decompensation, but he also had pain in the left hip, mainly during walking, for which he required NSAIDs. CT showed shrunken liver with no ascites, and there was some joint destruction in the left hip. Orthopedic consult was taken, and they said he needs left hip replacement for avascular necrosis. So these baseline labs with with a MELD score of 14 and child score of A, 6/15. Endoscopy showed varices. So he had bilirubin 1.8, albumin 3.3, INR 1.5, bit on the borderline, platelet count bit on the lower side 1.02, but overall he's okay. So
I think cable has been disconnected.
you have that mic, huh?
Caller mic? Caller mic, sir? I will just ask what you will do. Do you want to know?
No, but I'm never able to speak. Yeah.
You just take this mic. So you
That's okay. Thanks.
So you can ask questions right now. Okay, if any questions are there, any practical questions आपने कभी feel किया हो, फिर geometry fitness में problem आ रहा है, आप अभी भी जब तक strike start नहीं होती, you can just go for it.
Let's not waste the time and expect the faculty.
Yes, sir.
Patients with cirrhosis of liver and needs surgery. If it is below, this is a lower surgery is to be done in lower dose. Would you prefer spinal anesthesia?
It depends on the clinical conditions. Preferably, we should do spinal.
I had patients recently who had been in the cervical spine, 4 millimeter size, hematoma, psoriasis, NEERAJ. He had alcoholic hepatitis and he was to be operated for hip surgery. Which anesthesia should have been preferred?
It should be spinal is better. Spinal is definitely better.
I had a talk with anesthetist and he said we prefer general anesthesia.
That's the problem. So the anesthetists will have their own comforties.
I personally feel that sir, you let the anesthetist to decide.
Yeah.
Because they, if it is their comfort zone is there, is
Yeah.
not there, then it is not going to be successful.
No, that's fine.
Okay, so this type of which anesthesia is to be given, that's decided by the anesthetist. You can
No,
just
it's
see if
okay.
you don't have the list.
I'm okay. So, thank you. So, this patient is a 45-year-old with alcoholic liver disease, abstinent since 3 months, came with fatigue, found to have chronic hepatitis C, compensated cirrhosis, started on treatment. He also had left hip pain, for which he was found to have avascular necrosis and advised surgery. This was the baseline labs, bilirubin 1.8, well preserved, no decompensation. Child's A status, MELD is around 14 because of INR. And endoscopy showed early varices. So he was taken for surgery in outside hospital where he underwent total hip replacement. Intraop, he had 800 ml blood loss and he received 1 unit intraoperatively. Post-operatively, he had some inotropic support. He received 4 units of blood and he was also in NSAIDs and broad spectrum antibiotics, and biopsy showed avascular necrosis of the bone, maybe even tuberculosis, not sure. So this was his labs post-operatively. On 8th he was operated. So pre-op the bilirubin was 1.8. Immediate post-op it went up to 3.1. Child's A status with a 6/15 MELD score of 14 increased to child C status with a CTP 12 and MELD score of 22 because of shoot up in the INR 2.7 and rise in the bilirubin and fall in the albumin. And after 5 days, but however he was discharged from there, still he was not keeping well, so he was referred to us. After 5 days he came to us in emergency with bilateral lower limb edema extending up to the knees, decreased urine output, altered sleep pattern and hypotension. So there was obvious decompensation. And this was his labs at admission in our center, day for yesterday. 5.3 bilirubin, so it was 3.1 immediate post-op. After 5 days, 5.3, albumin 2.3, INR 2.4 with some sepsis and rise in creatinine. So he had and hyponatremia also. So he was found to have hemodynamic instability, AKI HRS, decompensation with ascites and grade 2 encephalopathy. So this classical case of post-surgical decompensation in a very stable patient. So I do not say the orthopedician decision is wrong to operate. So this is where we have to understand how to stratify these patients, who is fit and who is not fit. The numbers look fine, so there is no fault anywhere. But post-op, he had some bleeding and he required some inotropes, he required some NSAIDs. So in what way we can prevent, we could have prevented this problem. Although luckily patient is recovering now, counts are coming down, creatinine is stabilized, and probably he'll get discharged by today or tomorrow. So this is what presentation is about. So I'll first introduction. So cirrhosis is a significant cause of morbidity, mortality, with very inadequate surgical risk stratification. And as we all know, the number of cirrhotic patients are going to be rising because of rising Nash, as Dr. SAUMIN has already said, alcohol, and definitely aging viral hepatitis because of excellent drugs across the corner. And definitely with the rising age, they'll have more indications of surgery, any surgery, whatever it is. So, and cirrhosis, as we all know, has an increased risk related to general population, mainly because of wound healing, poor wound healing, impaired hepatorenal medicine clearance, and increased bleeding diathesis, which happened in our patient. And unfortunately, even the American College of Surgeons quality program surgical risk calculator, which is followed worldwide, they do not incorporate cirrhosis as an input, even now. So that is the dearth of the data in this subject. And they only said ascites within 30 days as one of the variable in their risk score. So I'll not take much of time in this. So this is the actual history of cirrhosis, compensated cirrhosis. Within 5 years, they develop deep compensation, and then after that, either they have to get transplanted or they eventually die. So, and if without even compensation, if the median survival is 10 to 12 years, when they decompensate, survival only less than 2 years. So, what is this critical mass concept? So, cirrhosis is nothing but end result of ongoing liver damage causing parenchymal necrosis, fibrosis that leads to architectural distortion and intrahepatic portosystemic shunts. So when this reserve is less, already there is less parenchyma, and whatever function parenchyma are there are hampered with this portosystemic shunts, intrahepatic. So they have very poor reserve, less toleration, and that is how they decompensate much faster in these patients. So now, if it is a normal liver, they develop ALF. If it is a compromised liver, they develop ACLF or chronic decompensation. That depends on the level of the insult. And surgery is one of the important causes of non-hepatotic causes of ACLF. So a chronic hepatitis, a chronic liver disease, like our patient, he was a compensated cirrhosis. But after surgery, he decompensated like an ACLF. He had organ failures, he had brain, he had kidney, he had hypodynamic instability. So he had 3 organ failures. So this is like a post-surgery related ACLF, like this chart shows. So now how do we give fitness for these patients? Who to go for surgery, whom not to go for surgery? So there was not much data at all. Different perspective to explain the thoughts. So coming to the first structural assessment. So how severe is the portal hypertension? That is a structural assessment. So portal hypertension is measured mainly gold standard by HVPG, which if it is more than 10, it means it is significant. So this is the free hepatic brain, and then we wedge it, and then we check the HVPG. So this was a landmark study which said HVPG can predict clinical decompensation, and it was done around 213 cirrhotic patients compensated, which over 51 months, 29% decompensated, and out of them, the 3 predictors of decompensation were HVPG, MELD, and albumin, and HVPG had the highest ROC curve. And the cutoff they found was 10. So HVPG more than 10 is clinically significant. So structurally, you can say the cutoff of more than 10 in these patients. So this is the different prognostication of using HVPG, and what we are standing here is with 10. which predicts decompensation, and many more levels are there after that, which is outside this talk. So what is a Baveno 7 consensus definition, consensus recommendations? Presence of clinical significant portal hypertension as determined by HbG more than 10 predicts higher risk of decompensation and mortality in patients with cirrhosis undergoing liver resection for HCC, which I wanted to say is any surgery, hepatectomy here, but they also gave a new statement. Non-hepatic abdominal surgery with HbG more than 16 also causes high short-term mortality. So here the take-home points are hepatic surgery, avoid with HbG more than 10. Non-hepatic surgery, avoid if it is more than 16. But it is, HbG is an invasive test, cannot be done in all the centers. So what are the more easier tests available? That is a non-invasive measurement. So if liver stiffness is less than 15, that is by fibroscan, and platelet count more than 1,50,000, it rules out clinical significant portal hypertension. So you can easily tell the patient is good. Whereas in a patient with virus or alcohol-related chronic liver disease, that is compensated cirrhosis, or non-obese NASH, if there is more than 25, it means it's clinically significant, so avoid. What about the between ones, 15 to 25? If it is 15 to 20 with platelet count less than 1.1 lakh, avoid. If it is 20 to 25 with platelet count less than 1.5 lakhs, avoid. So this is how we say clinical significant portal hypertension non-invasively. So that is a structural part. Now functional part, which is what most of us see, MELD score, CTP score, all that functional part. So this is the earliest, this is because of the editing in the laptop, so it's showing like this. So this is the earliest paper in 1999. Please ignore this part because it made in Max, so it is being shown in this as a different. A retrospective review of 733 patients of cirrhotics, and in them they found the 30-day mortality was 11% and complication rate was 30%. And in them they found all these different variables which predicted post-operative mortality. That basically sick patients and emergency surgery, high ASA score and elevated creatinine and so on. But this was the first study which gave a glimpse about post-surgical risk. Then further data came. This is the only landmark study which is available in this concepts. This is a study from Mayo Clinic where out of 772 cirrhotic patients, they did a retrospective study, and they found the main aim of the study was to determine the risk factors of post-operative mortality in these patients. And they subclassified, out of 772, they subclassified into different surgeries, that is hepatic surgeries, non-hepatic surgeries, colon surgeries, orthopedic, cardiovascular, and the ASA classification, they subdivided. And so if we see here, the mean MELD was always less than 10. So good patients, well-preserved patients, and most of them were fatty liver, rest were alcohol and virus. And in them, the independent predictors they found were, if the MELD is more than 8, age more than 70, ASA class 4, that is severe advanced liver disease patients, or emergency surgery. And in them they saw as the MELD score is increasing, the mortality is rising and the survival is falling. So MELD score of 5, it was survival was 4.8 years. It came down to 14 days survival by after MELD of 26. So as the MELD score is increasing, the survival is poorer in these patients post-surgical. And the important take-home points here are less than 7-day mortality, ASA score determines that. More than 7-day mortality, MELD score determines that. So that is, so this study basically determined the post-surgical mortality risk, not decompensation, mortality risk. So and this is how they give the scoring system. So our patient had all these parameters at baseline before surgery. So when such patient comes to us, we say with the Mayo risk score, the mortality risk score for you is so and so. 7-day mortality 2%, 30-day 10% for our patient. So this is only mortality, but if a patient asks, what is the risk of me getting jaundice, what is the risk of me getting ascites, we don't have an answer. So this is one of the important limitations of the Mayo risk score. It's a single center study, And it was done quite long back in 2007 when the surgical techniques were not that advanced. And they do not, most importantly, they do not give the risk of decompensation. Only they give mortality risk. There's another study which came after that about the factors which predict outcome of abdominal operations in patients. Only abdominal, not other operations. And it was a retrospective review of 100 cirrhotics, and this was the common morbidity they found in their patients. Most common was wound complication like infection, hematoma, which we all usually expect. And 30-day mortality was 7%. So when they stratified with child score and MELD score, as the child score increased, as we expect, the morbidity was 80% and mortality was 12%. Even the MELD score, 100% morbidity if it is MELD score more than 26, and no survival if it is more than 26. And the independent predictors they found were intraoperative transfusion, albumin very poor. I mean, functionally they are bad with low albumin, raised bilirubin, and presence of ascites, and intraoperative stomachose. Our patient had intraoperative transfusion, and ASA score was more than 3, and he had bilirubin more than 1.5. But he did not have ascites, he had good function. Still our patient decompensated. And blood loss also was there. What about any new other paradigms are there in this gray area? So this is one indocyanine retention test, ICG, which is mainly used in Japanese population for hepatectomy. But this concept can be used even for defining portal hypertension. And they found that if it is less than 6.7, it can rule out clinically significant portal hypertension non-invasively. More useful and more simpler for us is this new grading, ALB grading, that is albumin bilirubin grading. This has also come for detecting the functional reserve in patients with HCC when they go for hepatectomy. But the same concept can be employed for this group also. So this is mainly used by this is mainly calculated by adding serum albumin and bilirubin in these patients, and they give grades. And in this study they found it is significantly more accurate than CTP, MELD score, and even ICG for predicting post-hepatectomy liver failure. So this mainly a functional reserve this score defines. Similarly, this is the new EPOD score, that is early prediction of decompensation. Now we all had only one thought in our mind: what is the risk of decompensation in these patients? So this is the only score which is right now which have combined both functional and structural component of liver disease. So the functional component is albumin bilirubin, and the structural component is platelet count. So by combining these three, they said the risk of decompensation we can predict. So this is how the score is calculated. It's available online, and this is the ROC curves, which is definitely better than MELD and CTP. And the cutoff they took was 10. So we spoke about structural assessment, functional assessment by MELD, CTP, EPOD score. What about physical assessment? That is, all the liver disease patients have so-called sarcopenia and frailty. And this is the different mechanisms for that. I'll not go into the detail. So how we say performance status, it is not that simple in liver disease as we say for cancer. Liver disease even though they may be well built, but they are very poorly nourished because they have low muscle mass. This important one of many frailty scores are there. Commonly we use is liver frailty score. So this is a liver frailty index by grip, hand grip strength, number of chair stands, and tandem walking. Very simple bedside test. And we give a score of more than 4.5, it means frailty. And this is what the commonly we use is liver frailty index and 6-minute walk test for our patients. How to define frailty. And there's enough data is there. When the patients are frail, they have more of perioperative morbidity mortality. This is mainly used for transplant setting, but this equally holds true for major surgeries. The last CPET, that is cardiopulmonary exercise testing. I'll not go into the details, but we already know cirrhosis has a very peculiar cardiovascular profile because it's a vasodilated state, low vascular resistance, and so on. And also a component called cirrhotic cardiomyopathy. So we usually do structural cardiac assessment by ECG echo, but also functional also is equally important. That is just metabolic equivalent of tasks or 6-minute walk test and so on. So upcoming data is there about usefulness of this test to give fitness in your patients. Finally, something to think about. See, all the patients of cirrhosis, will have some acceptable surgical risk. But they are denied elective surgery because we are scared to give fitness. And usually we say, until the patient has an emergency, we'll see. Dekha jayega baad mein. So common example is a liver disease patient with umbilical hernia because of some mild ascites, but good liver function. So will you give fitness or not? Definitely no. Most of us, 100% will say no, will not give fitness because they don't want risk of decompensation. We will do surgery when it is incarcerated or some emergency. But this is a high mortality scenario. So we have to understand how to stratify these patients and then give fitness and tell the surgeons and the anesthetist, keep a short surgery time, give a small anesthesia, avoid blood loss and do a quick surgery. Then there will be no risk. So take home message, just only the cutoffs I'll be giving. If it is a compensated advanced liver disease or compensated cirrhosis with no clinically significant portal hypertension, CTP A or B, MELD less than 10, ALB score grade 1 or EPOD score less than 10, no clinically significant portal hypertension, either by HUPG less than 10 or FibroScan less than 15 with platelet count more than 1.5 lakh, good cardiopulmonary assessment, good frailty index, that is they are well built and not sarcopenic, and definitely most importantly, multidisciplinary approach, involve a cardiologist, nutritionist, physiotherapist along with you when for pre-op selection, optimal intra-op management, and definitely very close post-op management. Thank you very much.
Any questions? Welcome. Any questions to Dr. Chandan Kumar?
For a patient of cirrhosis and ascites, if somebody wants intra-abdominal surgery like umbilical hernia, so would you like to go for tapping paracentesis and before going for surgery? How you prepare? And you give albumin before the surgery?
If the patient has cirrhosis with ascites but good liver functions with small early small varices, and otherwise his frailty index is, like I said, that cutoffs, then we better put a pigtail, drain the ascites, because if the ascites is, he will have post-operative ascites also, and that ascites will leak, it will cause surgical complications, impaired wound healing, infections and all. Put a pigtail, make him dry tap, then send for surgery. Keep the pigtail post-op also till the wound heals and then remove the pigtail.
Sir, not
Yes.
as a doctor but as a nutritionist, I have a couple of questions. The one is, if it is elective surgery, do you have any protocols regarding sarcopenic patients, so for increasing muscle mass or any protein supplement in your hospital?
Yeah.
Is there any protocol?
So we are doing this study now. It's called, it's my student thesis, where we have a strict we follow a nutritional protocol with late night snack and some amount of calories, some protein, and small frequent meals. And we also keep doing the frailty index in them. How every weekly we follow up with them, how much calories they're taking, how many steps are they walking, they maintain a diary. And then we also manage them medically closely. And this is how we do something called physical rehabilitation, nutrition rehabilitation, and medical rehabilitation. So all three components are important in liver disease.
So if it is an elective surgery, that is okay, but sometimes there is some emergency surgery.
So in
a very narrow window, how can you optimize the
you better put Riles tube and start feeding them, because when they are so sarcopenic, they'll not have that much appetite. And preferably, we try to manage them medically and optimize them before going for surgery, however emergency it is, because otherwise if sick patient, if you do emergency surgery, better explain them very high risk and then proceed.
So according to you, even if patient is taking orally, you can put Riles
Yes.
tube to build up the patient?
Yes, that's true.
Thank you, sir. Thank you.
But I think, sir, emergency is emergency. We don't have much window to make potentially. So I personally, this is my personal emergency, you have to go for
No,
it.
that's what the Mayo risk score and all showed. If it is emergency surgery, they definitely have higher risk, but we have to take the necessary precautions post-op also accordingly.
But I feel liver frailty index, that in elective surgery, I personally feel that you should assess apart from child and MELD score. So that will give you another fair idea about the post of decompensation and complication.
The operative fitness for the patient.
So I think that was we are missing in our practice. We used to calculate liver frailty index, Dr. Bidita, but in general what I have seen in the references, this aspect is missing. We are not going to calculate the liver frailty index in pre-op fitness. So it's otherwise it's a simple tool, it is available, nothing, it is just a bedside tool. But I think we should, and if it is just say it is more than 4.5, I think, then we should take decision according to that.
When should we use coagulation factors and platelets post-operatively in cirrhotic patients?
Sorry.
When should we use coagulation factors and platelets in post-operative scenario?
We follow something like thromboelastogram and all, sir, because they will have always impaired coagulation, they will have low platelet count. But if the TEG is deranged, then treat only that part. Suppose they have low fibrinogen or they have platelet dysfunction, give platelets. Yes. So it depends on the fluid balance in the patient, because if you give more FFP, they'll have fluid overload, and better give single donor platelets than random pool platelets. Less than, if it is platelet count is less than 50,000, or there's active bleeding is there. For example, patient has hemoperitoneum or wound bleeding is there, increased blood is there. Yes, we have to give coagulation factors. We have to check for fibrinogen level and give cryoprecipitate is required, or give platelets post-operatively. Pre-operatively we don't give anything. No, pre-operatively nothing to give. No. You keep on reserve only if required intra-op and post-op, not pre-op. There's no point in correcting pre-op because nothing will correct.
So,
Sorry, I got the question wrong. 100%. If you want to go for surgery, 100%. Without that, if upper GI scopy shows varices, better prognosticate them before, explain the risks and better delay.
In case of autoimmune hepatitis, is there any protocol whether the immunosuppressive drugs has to be stopped or that has to be continued?
In pre-surgery you're saying?
Yes, perioperative period.
Perioperative, see, immediate pre-op, if they are on Visalon or azathioprine, better continue if there is no sepsis issue. Post-operatively, wait for a week until the wound healing happens, because in post-operative period, they'll always have immune paresis because the body is in stress post-operatively. So unlikely they'll develop a relapse of autoimmune hepatitis. So let the wound healing happen, let the patient get discharged. On OPD basis, you can restart the immunosuppression drugs.
So Chandan, very good talk.
Thanks.
And a lot of good comments. Just one thing I wanted to, maybe you can share with the audience. Many times there is also a lot of discussion about what antibiotics the patient should receive, what analgesics the patient should receive, what sedation the patient should receive. And it is I at least find it very diplomatic to convince the orthopedic surgeon, or because everybody has their own preferences. They use left, right and center NSAIDs, they use sulbactam containing antibiotics. So how do you put it across, and what is your advice regarding that? Because this question is commonly asked when you give fitness ki kya use karna chahiye, kya nahi use karna chahiye. So
that's an extremely practical question. This patient, I didn't say that, but this patient had received amikacin, combiflam, all kinds of things post-op before he came to us. So always avoid this ibuprofen, diclofenac, all these NSAIDs post-op. The most safest analgesic, because that's also limited data is there, is paracetamol or maybe paracetamol and tramadol combination. I don't think anything works more than that. Even for post-transplant also, we don't use anything more than that. Avoid that. Second, avoid nephrotoxic drugs like amikacin, streptomycin. Even if this patient, suppose he has TB also in the bone, if we find, we'll not give him streptomycin. We'll manage with other drugs. We can start with, that is, I think one of the talks, Dr. Mithun will be saying how to treat ATT in cirrhosis. So drugs and nutrition is the one we have to manage. Antibiotics, you can use broad spectrum like penicillin group, like piperacillin, tazobactam, carbapenems, they are safe.
Magnex Fort
Magnex.
apparently one of the hot favorite drugs, or many times we see, at least
See,
in orthopedic
that's
surgery,
what-
linezolid is very favorite.
That's true. But see, now our patients have a good functional reserve. Otherwise, we don't give fitness for surgery. So I think better we should give emphasis on painkillers, analgesics and all. Antibiotics, I don't think if we start restricting in that also, then we'll be very constrained settings will be there.
I think, sir, in our Indian setup, patient is more complicated due to the sepsis rather than the liver failure. So even a sulbactam containing or linezolid is not practically so harmful to the liver, because usually we operate in child B status. Okay, so even with sulbactam containing, if you stop a Magnex Fort, okay, so whatever the surgeon, they will directly jump to the meropen.
We should not do that. We should not do that.
So I personally feel antibiotic you can use, but yes, amikacin, that will precipitate a more kidney injury, particularly in the cirrhotic. When albumin is less than 3, you should be more careful, because it will immediately precipitate the kidney injury, and this is a fatal combo, liver and renal. Then chances of survival will be reduced. So I think we should be more careful, even in cirrhosis, which antibiotics injures the kidney rather than the primarily injures the liver.
It's all about prevention of organ failure. That's all.
And I just want to ask, apart from child MELD, any particular index practically you use prior to the fitness?
I think this is the new score, EPOD. I think that is very
It's
good.
very good? Okay. So
early
this is
early
your-
prediction of decompensation. More than 10, better avoid. Because it takes both the structural and the functional component of liver disease.
And any specific parameter which is difficult to get, or it's a very simple score?
No, EPOD is only platelet count, bilirubin and albumin. It's
So this is
online
something
calculator.
new we can use for
It's
pre-op
just come
fitness.
in 3 months back in Liver International.
And simple 6-minute walk test tells a lot about the
Frailty,
patient. It is
yes,
very easy
yeah,
to
yeah.
use. I think so. We should make it a ritual that simple 6-minute walk test should be used for any
Less than
surgery
250
in a liver
meters.
patient.
Less than 250 meters, avoid.
Sir, excuse me. Hello.
Hi.
Sir, a diabetic patient with the cirrhosis of liver, otherwise compensated disease, having obstructive sleep apnea, chronic hypoxia related polycythemia, presented to emergency with the convulsion, MRI suggestive of brain abscess with pressure effects. In labs, hemoglobin is 19, platelet is 70,000, otherwise LFT is good. So how should we proceed for the pre-operative fitness, and what post-operative measures we should take?
See, first, if the neurosurgeon feels by by draining of the brain abscess, there will be improvement in the neurological condition, platelet count more than 70,000, liver functions are relatively okay, I think we should proceed. Because active sepsis, if you don't treat, the patient will not improve. But we have to tell the risk of decompensation, but that is, the mortality risk is still less compared to brain abscess mortality. So keeping the blood products and the risk profile in mind, we should proceed and treat, and then post-operatively keep them open that, see, suppose if you have decompensation or advanced decompensation with organ failures, but brain otherwise is improving, then you should keep a standby for transplant also if necessary, if required. That's the way we should counsel patients.
Sir, any post-operative care or medicine that can avoid decompensation?
Avoid. I think that's what we discussed about NSAIDs. And maintain the adequate hemodynamics and nutrition, and all the drugs should be screened carefully.
Chandan, if I may pitch in, at least I see lot of trend of this IV glutathione being written, IV N-acetylcysteine being written. It's a practical thing. Everybody will have IV Alcomax. So please give your comments about that, so that the audience takes a crisp take-home message.
Yes, yes.
That's a vast area. I mean, pharma-driven that is. So I don't believe much in that. Only one study is there on use of N-acetylcysteine in non-paracetamol liver failure, which is used across. That single study has made a huge business for N-acetylcysteine and glutathione and all the antioxidants. But personally, I don't use much of these things. So, but there's relatively safe. There's no harm in using it, but you cannot say that this prevents, this helps. We can just give.
We will be taking only one question, or are we done with the questions? Last question.
Platelet count, I think more than 50,000. For if surgical risk, it should be more than 1.5 lakhs or at least 1.1 lakh. But for cutoff for emergency surgery, at least more than 50,000. No. Then we explain the risk, but we don't, like I said, we don't need to transfuse pre-operatively. We have to counsel anesthetist and the surgeon. No need to transfuse. Intra-op or post-op if required, you should transfuse.
Basically, now almost this practice is driven by thromboelastography. What to transfuse, what to not transfuse. But in general, only deranged INR in the range of 2-3 or a less platelet doesn't mean you have to transfuse prior to the surgery. Okay, but you can keep it reserved because cirrhotic coagulopathy is little bit different. Cirrhotic is a balance of coagulation as well as anticoagulation. You can see the portal vein thrombosis in cirrhosis. You can see the DVT in cirrhosis. Okay, so just INR is a true marker. Platelet is not a true marker that this patient is going to bleed or not. But for safety side, you keep it reserved. And if it is required, you give it intra-op or post-op. If
so
surgeon
like SAUMIN said, suppose if the anesthetists or surgeons are worried about the INR, you start just before the surgery and take the patient to OT on FFP for their satisfaction, even though it's not going to help much.
Sir, is there any role of intravenous ascorbic acid?
Intravenous?
Ascorbic acid.
Like I said, antioxidants is a huge, I wrote a paper also on that. There's no magic bullet. Yes, sir. Like I said, sir, it depends on the stratification. Child's A, Child's B, Child's C, or MELD score, that study which I showed in 2010 study. So Child's A, survival rate 70%, more than 70%, Child's B 50%, Child's C 20%. 30-day mortality rate. Survival. Yeah, abdominal surgery. But like I said, there's not much data in this, but we can stratify in this way, or preferably can give the Mayo risk score because it gives 7-day, 30-day, 60-day and 90-day mortality, objectively. Yes. So because the Mayo risk score has given for abdominal surgery, cardiac surgery and orthopedic surgery. So for any surgery, non-liver surgery, we can use this score for mortality risk.
So we'll stop this session here. Thank you, Dr. Chandan.
Thank you.
It was really an interactive session. And I request Dr. Manish Desai to felicitate Dr. Chandan Kumar. And thank you, all the chairpersons, for conducting these interacting sessions.
After this great interactive session, we are moving forward to our next session, that is ALF, acute liver failure, optimization in non-transplant centers. And for that, we have today, we are privileged to have a great academician, Dr. VINIT SHAH, and I am sure no one would better justify this topic. So I invite Dr. VINIT SHAH and the chairs for this session, that is Dr. Paras Roy, Dr. C.D. Lalwani, Dr. K.N. Bhatt and Dr. M.G. Solu. Please come on the stage, the chairs. And Dr. VINIT SHAH, the board is all yours now. I request Dr. Praful to please introduce the speaker.
Dr. VINIT SHAH was Senior Fellow in Department of Interventional Gastroenterology and Hepatology at Medanta. Currently, he is working as a consultant in hepatology and liver transplant medicine at Ruby Hall Clinics. He has so many presentations, and he is a member of prominent bodies like ESL, ASLD and INASL. So the stage is yours, Dr. VINIT.
Yeah. First of all, at the outset, I would really thank Dr. SAUMIN and Gujarat Gastro and Vascular Hospital for giving me an opportunity to talk on this topic. I am really fascinated to see such a interactive audience on a Sunday morning. So my topic for discussion today is acute liver failure optimization in non-transplant centers. Basically, it is a very important topic because this is a very common entity which we see, and many times it is missed. The important thing about this entity is if it is missed and precious time is lost, very high probability we will lose the patient. We are residing in an area where we have a lot of malaria, dengue, chikungunya, and now the rainy season, this is bound to increase. So we have many conditions also which mimic this entity. So it is very important to have a good interactive discussion about how to identify that the patient is not doing well, when to timely refer the patient, and what are the basics of management. So I would just want a show of hands in this audience. How many are dedicatedly working in a critical care setup? I mean, predominantly intensive care. Is there audience in this? Okay, so I would make the topic more discussion wise with the physician oriented things, because this is a topic where the intensivists also have a very important role to play. So I would start my discussion with a case. So we have a 30-year-old lady who presents to the hospital with a 2-day history of nausea, vomiting and right upper quadrant pain. She has been healthy and denies any medication use. She recently traveled to Uttarakhand where she twisted her ankle during a bungee jumping enjoyment. The pain had been well controlled with over-the-counter and natural remedies. So on examination, she is slightly confused to date and in moderate distress for the pain. Vitals wise, her blood pressure is 122/40, heart rate is 108, respiratory rate is 24, saturation is 95% at room air. She has diffuse abdominal tenderness, palpable liver edge with scleral icterus. So now what is the most likely cause of this patient's presentation? As we know, the topic is on acute liver failure. We should know what are the common etiologies of acute liver failure. So it is a very easy thing to remember if we remember it as a mnemonic of A, B, C, D, E, F. So A, the most common are acetaminophen or paracetamol. Second is hepatitis A. Third is autoimmune. B, obviously hepatitis B. C is cryptogenic or hepatitis C. So there are some acute liver failures where we don't find out the cause even after exhaustive evaluation. Hepatitis D. E stands for historetic causes like Wilson's and Budd-Chiari syndrome. And F is some things which are seen peculiar in pregnancy, like we see acute fatty liver of pregnancy, etc. So again, coming back to our case, her blood work showed SGPT level of 3,826, SGOT level of 4,826, bilirubin of 9, INR of 4.2, creatinine 1.1, pH of 7.31. So here it is very important to have a very good history. Many times patients coming with acute liver failure are disoriented. So it is very important to involve the family members and take a detailed history. So these are the 4-5 important points in the history which are very important, which may give us a clue. So one is travel history. So it is very important because if you traverse the geography of India, there are certain causes of acute liver failure which would be very common in certain geographical locations. So any North India travel, generally hepatitis E would be a very important cause. We don't see that much of hepatitis E in our Gujarat, Maharashtra side, but in North India, hepatitis E is a very important cause. The second is over-the-counter drugs. We all know that paracetamol in India is not a prescribed drug. It is easily available over-the-counter. So history of over-the-counter drug intake is very important. Third and the most important thing which is nowadays coming up is consumption of alternative and complementary medicines. So we see
lot of alternative complementary medicines being taken nowadays for all kinds of reasons. And this history is very important while identifying acute liver failure cause. Now all the data from India is showing that complementary and Ayurvedic medicines is in the top 3 causes of drug-induced liver failure. The other very important history relevant to this age group is amenorrhea. Many times a young female who comes with acute liver failure, it is very, very important to rule out pregnancy because that can dramatically change the management plan. So in any childbearing age, it is very important to rule out pregnancy when a young female comes with acute liver failure. So coming to the acute liver failure, it was a term which was coined by O'Grady in 1993. The most accepted definition is the one which is proposed by American Association for Study of Liver. It tells us that there are 4 important components to the definition. One is a rapidly progressive jaundice of less than 26 weeks duration. So the jaundice has to not label anybody to have acute liver failure, and it has to be a rapidly progressive type of jaundice. The duration may vary if you use other society definitions, but on the whole, less than 26 weeks of rapidly progressive jaundice. The other important thing which is very important to define acute liver failure is coagulation abnormality has to be there. Without coagulation abnormality, again we cannot label it as an acute liver failure. So the INR has to be more than or equal to 1.5. The third and very important component of acute liver failure is altered mentation. So some degree of encephalopathy has to be there. Again, only INR high, bilirubin high, and the patient is walking, talking, you cannot label it as acute liver failure. Altered mentation or some degree of encephalopathy is a very important component of acute liver failure. And the last and most important component which I would discuss in subsequent slides is there should not be any at least known history of pre-existing liver disease. So these are the 4 components. I would again reiterate: rapidly progressive jaundice, coagulation abnormality, any degree of altered mentation or encephalopathy, and without any pre-existing liver disease. So you can define acute liver failure only and only if the patient meets these 4 criteria. All the 4 criteria are very essential to label the patient as an acute liver failure. Now, there are some situations which are very peculiar to us, especially Maharashtra, Gujarat side. This is one entity which we used to very commonly see in South India, in Karnataka, Tamil Nadu especially, yellow phosphorus or rodenticide poisoning. I am not aware if it is that common in Gujarat also. It is a very, very important cause of acute liver failure. Why it is important? Because there is a therapeutic modality known as plasma exchange which works very promisingly in this entity. This entity has a very rapid progression to multi-system involvement. Also peculiarly, this rat killer poison or yellow phosphorus poisoning has a lot of cardiac, bone marrow, pancreatic rituals which we should know by heart. At least any good physician practicing good liver disease should know King's College criteria, because this is a very important way to identify the patients. So it was a criteria which was widely developed over an analysis of almost 600 patients at the prestigious King's College Institute between 1973 to 1987. So basically the criteria are separate for paracetamol-induced acute liver failure and non-paracetamol. So paracetamol-induced acute liver failure, arterial pH less than 7.3, even adequate volume resuscitation. This is very important. Without adequate volume challenge for at least 4 to 6 hours, we cannot label it as this. So pH which is not improving even after adequate volume resuscitation is directly qualified as acute liver failure due to paracetamol. Or the other aspects of the criteria are combination of encephalopathy grade 3 or more and creatinine more than 3.4 or INR more than 6.5. So this is a important criteria for paracetamol. we see very less paracetamol. At least I have not been able to see much of paracetamol ALF in Pune at least. I don't know what is the practice here, but I am sure paracetamol-induced acute liver failure is very rarely seen nowadays. Non-paracetamol, a single INR more than 6.5 is a very important criteria to define acute liver failure, or it should be 3 out of the 5. So irrespective of the grade of encephalopathy, duration of jaundice before onset of encephalopathy more than 7 days, INR more than 3.5, bilirubin more than 18, age less than 10 or more than 40, induced liver injury seronegative. So your hepatitis A and B are negative. So if 3 out of the 5 criteria are satisfied, then again it's a poor prognostic marker for acute liver failure. There are some advantages and disadvantages of King's College criteria. Although fulfillment of this criteria has a very high specificity for predicting that the patient will die, the sensitivity and negative predictive value remains low. It incorporates etiology and clinical parameters in the definition, that is important. But the most important drawback is not fulfilling the criteria. There are patients who may not fulfill the criteria. So to circumvent this drawback, this is a criteria which everyone should be proud of. Out of time, the should see are one is presence of advanced hepatic encephalopathy. Many times we, but overall in liver, these are bilirubin, because these criteria which are studied on so these are the 4 criteria as I told you. They showed that INR which is more than 5 at admission or it is rising to more than 5 on 3. Hepatic encephalopathy is more than grade 2 on admission, grade 2 at 3. Ammonia which was less than 23 or it is arterial ammonia. We should not order for plasma or venous ammonia. It has to be arterial ammonia and it has to be processed in a particular way, because it has been studied that the arterial ammonia has the most important predictability. So we should order the ammonia in a proper way. So the best cutoff values, as I told again, INR which is more than 5 or admission, or it continues to be more than 5 in spite of medical treatment on day 3. Arterial ammonia which is more than 123 on admission, or it continues to be more than 123 after 2 days of treatment. Bilirubin which is either more than 15 on admission or it continues to rise to more than 15. And encephalopathy which continues to rise is an important predictor that this patient is not going to do well. So again, from today's talk, my take-home message will be these 4 criteria are very important: arterial ammonia, bilirubin, INR, and hepatic encephalopathy. Now coming to the management of acute liver failure, it is a teamwork. The liver specialist, intensivists, surgeons all have a very important role to play. Without a good teamwork, acute liver failure cannot be managed properly. Now coming to the intensive care aspects, I would touch upon the broad points. One is how to support the vital functions, how to avoid complications, how to identify patients who are not going to do well. So again, this ALFED model which I discussed is very important on day 1 and day 3 assessment. Optimizing the conditions for liver regeneration, optimizing the conditions that at least if the patient is not medically doing well, we keep him in a good shape enough so that if at all the patient goes for liver transplant, he is in a shape where the transplant is going to be successful. Patient who is not medically doing well, who is going into multi-organ failure, will not be a candidate for transplant. So at least as good physicians and intensivists, we should manage the patient in a way that he remains in a good window for transplantation. So the support to vital function means how to support the central nervous system, how to support the respiration, circulation, what is the role of extracorporeal therapies, how to manage the coagulation system, how to manage the infections, and how to manage the metabolism of the patient. So this is a very easy bedside West Haven criteria for hepatic encephalopathy. Again, it is very important to know this criteria because encephalopathy grading, it is easy on a bedside basis that we grade the patient. Now coming to management of central nervous system, where the most important key is management of raised intracranial tension. So these are very small basic things, but they have a long-reaching impact in the good management of the patient. Head and elevation 30 degrees, minimum stimulus to the patient, nursing the patient in a dark, quiet room. We should all train our sisters to, or the staff looking after the patient, to do pupil monitoring every second hourly. Pupil monitoring is a very easy thing which can be taught to the staff, and it plays a very important role to identify in which direction the patient is going. Now coming to the various pharmacotherapy, so there is maybe some doubtful role of rifaximin in preventing bacterial translocation, but use of lactulose, use of L-ornithine L-aspartate, use of glutathione, use of S-adenosyl methionine, use of UDCA, there is no role in acute liver failure. There is no literature to support these drugs in acute liver failure, and we should not be using those drugs when we have labeled a patient as acute liver failure. Yes, definitely there is data about N-acetylcysteine. It is a very important drug in paracetamol-induced acute liver failure. Also, as Dr. Chandan told, in non-paracetamol related acute liver failure, there is some data about using N-acetylcysteine. But again, it has to be used in a particular dose. So the recommended dose is 150 milligram per kg per day as a slow IV infusion with continuous sodium monitoring. So using a subtherapeutic dose will not help the patient. So if at all it is used, it has to be used in the right dose. Slide is not moving. Yeah. Now coming to the very commonly used drug, mannitol. How should we use it? So mannitol, it is used in a 100 ml IV bolus, 2 gram per kg, 2 to 3 divided doses. It should be started only after careful discussion. It should be used only in cases with grade 4 encephalopathy or all encephalopathy patients with clinical or imaging evidence of raised ICT. Very, very important take-home message, not to be used as a round-the-clock medicine. So there is no role of writing IV mannitol TDS. It has to be used only in a bolus form. It should be used only when there is grade 4 encephalopathy or encephalopathy patients with clinical or imaging evidence of raised ICT. Monitoring the serum osmolality daily is very important, and it should be stopped if osmolality is more than 320. It should be not used if the patient is having a serum creatinine more than 3.5 or oliguria. Urine output should be carefully monitored when you are using mannitol. It should be more than 1.5 times the bolus volume in next 1 hour. So very important that mannitol should not be used as a round-the-clock medicine. Again, there is good data to use hypertonic saline. The target sodium in all acute liver failure patients should be 145 to 150. This should be the target level. Now, there are some ways where we can monitor the raised intracranial tension. In a basic ICU setup, at least the intensivist can be trained to see for optic nerve sheath diameter. That can be trained. That has a decent role to judge raised intracranial tension. The gold standard is transcranial Doppler, but it is very difficult that the transcranial Doppler facilities are available in all setups. But at least optic nerve sheath diameter monitoring should be done. There is some role when the patient is on ventilator of hyperventilation, maintaining the PCO2 between 32 to 35, especially during the episodes of raised ICT. Monitoring the electrolytes and urine output is very important. Now coming to the ventilation strategies. So this is another important take-home message. Elective intubation should always be done in acute liver failure. it is no problem to over-intubate the patient, especially if you are referring the patient and transporting the patient to a higher center. It is always better to be more proactive, intubate the patient. If the patient reaches the referral center, if he is really doing well, he can be extubated. But in the transit, if the patient's airway is not protected and you get aspiration, that is the worst thing which can happen to a patient. So the dictum is, when you are in doubt, it is better to over-intubate. At the most, the patient will reach the center and he will be extubated. But there is no harm in intubating the patient. Elective intubation in all grade 3 and grade 4 encephalopathy patients. So this is the important message I wanted to give. Always intubate before transport to a transplantation center. Avoid high PEEP when the patient is on ventilator. Hyperventilation, I already discussed. The PCO2 should be kept between 32 to 35. Now coming to the sedation in acute liver failure, by far the best drug to be used is propofol, because propofol has a good effect in reducing the raised intracranial tension. So as far as possible, we should try to use propofol. If there is asynchrony on ventilator, you can use atracurium. Fentanyl, it is better to avoid. Barbiturate should be used only if the patient is not a candidate for transplant. Benzodiazepines or midazolam should be avoided. So another take-home message is we should avoid benzodiazepines as much as possible in acute liver failure. We should try to use propofol as much as possible. Coming to management of seizures and how to extubate. So extubation to be planned only after sensorium has improved. Now what are the indications for doing a CT brain? Any focal neurological deficit at admission, CT brain should be done. All patients with grade 4 hepatic encephalopathy development during management, CT brain should be done. For patients who are about to undergo transplant, before rolling them into the operation theatre, a CT brain should be done for acute liver failure. So these are the indications where a CT brain should be done. Management of seizures, pre-transplant phenytoin can be used, post-transplant levotiracetam. Barbiturates are reserved for patients who are out of transplant list or who are not candidates for transplant. Coming to management of circulatory system, noradrenaline is generally the vasopressor of choice. DNS is the fluid of choice. Other fluid strategies can be guided by the investigations of the patient. So circulatory system, we should optimize the blood volume, optimize the vascular tone, good cardiac support, and definitely acute liver failure is one condition where steroids do have some role. Basic principles, as I reiterated, head and elevation, keep the neck in central position, nursing in a quiet dark room. Antibiotic protocol can vary from each ICU to ICU according to the local antimicrobial biogram. IV piperacillin, tazobactam, ticoplanin is a thing which we use. Now, acute liver failure is a condition where empirical use of antifungals is definitely recommended, and there should be a good antifungal in the prescription of acute liver failure, because this is where one condition where the risk of fungal sepsis is very high. So definitely you can use antifungal depending on your antimicrobial or antifungal biogram of your ICU. There is something known as indeterminate ALF. So even after exhaustive workup, we cannot find out the cause of ALF. So there is some data for the use of acyclovir in such cases of indeterminate ALF. Nutrition, RT feed should be started at the earliest in all. Maintaining the gut trophicity is very important. So RT feed should be started in all. Stress ulcer prophylaxis is also very important indication. Now coming to the very important topic of coagulation management in acute liver failure. So again, one take-home point which I would like to give is there is no role of empirical FFP transfusion. There is no survival advantage. Studies have shown that even though the INR is high, the IC bleed risk in acute liver failure is actually quite low. So empirically, just looking at the INR and transfusing fresh frozen plasma is not indicated. No prophylaxis is indicated as per INR. The disadvantage of this practice is it will falsely cause our INR normalization, As I told you, in our ALFED model, the INR is a very important marker to see how the patient is behaving. So if we keep on transfusing FFP, we will not be able to clearly judge that in which direction the patient is going. So in absence of clinically significant bleeding, empirical FFP transfusion, just looking at the INR should not be done. The other disadvantage is that when we use FFPs, it may complicate our decision for liver transplant. It may increase the risk of volume overload. Vitamin K may be used, and with invasive procedures, again, you can use FFP. But for simple procedures like Wright's tube insertion, again, FFP transfusion has no role.
Sorry to interrupt, sir, but you have 5 minutes
to
wrap up the session.
Yeah. So coming to this, the TEG is a very important thing where we can judge the coagulation system and give the blood products. So I will just hurry. There is very good role of extracorporeal therapies in acute liver failure, where this early institution of CRRT, that is CVVHDF, is a very important marker. At least what we use is when 2 arterial ammonias are coming above 80, we should try to use CRRT at the earliest. Studies have shown that institution of CRRT has a very good role in reducing the raised intracranial tension. There was one good paper where they looked at high volume plasma exchange in acute liver failure, where they showed good transplant-free survival. I think so there should be more learning towards using plasma exchange in a proper way in acute liver failure. As I mentioned, plasma exchange has a very good role in yellow phosphorus poisoning, and generally now there is lot of trend towards preemptively using plasma exchange in something known as acute liver injury due to rat killer poison, where bilirubin more than 2 or enzymes more than 500, INR more than 1.5, even without encephalopathy, you should try to institute plasma exchange early in rat killer poison. Now, coming to some special scenarios, many times you get acute liver failure due to Budd-Chiari syndrome. Good endovascular treatment with a good interventional radiologist can salvage. Acute liver failure due to presumed autoimmune hepatitis, transjugular liver biopsy, and you should try to institute steroids, although the risk of fungal sepsis is high. Generally, worsening encephalopathy with autoimmune hepatitis, it is better off to consider them for transplant rather than trying steroids. Now, coming to the timing of transplant, last 2 slides. So, it is a very important confusion. Are we referring the patient too early because this is a condition where spontaneous recovery is possible, or it is too late when there is permanent neurological damage, renal injury, infection, which may render the patient as not a candidate for transplant. So when to refer? Confirmed acute liver failure as per the criteria which I mentioned, either KCH or ALFED. In Indian setting, this ALFED criteria of AIMS are very good. Arterial ammonia trend is a very good important marker. Trend of bilirubin and INR is very important. When not to refer, when you get evidence of permanent neurological damage like abnormal pupils, abnormal CNS examination, seizures, evidence of bleed or lot of intracranial edema, signs of infection like persistent fever, organ dysfunction, and renal failure with a rising creatinine or oliguria. So generally what we do, we discuss the option of transplant at presentation, identify the donor and start the workup, follow the patient over 48 to 72 hours, worsening we may take him for transplant, improving we wait. So I thank you for your patient hearing and would be very happy to answer questions.
Thank you, Doctor.
We can take couple of questions. We can obviously take couple of questions.
No, I am not asking the question. I am chairperson.
Sorry, sir.
1 minute.
I was just telling we can take couple of questions, sir. Sorry
1
if
minute.
it was misconveyed.
Thank you, Dr. VINIT Shah, for excellent and point-wise presentation on ALF. Now we can invite the questions. Before that, I wish all the fathers happy Father's Day.
Thank you, sir.
You said regarding mannitol, 2 to 3 times a day, 2 grams per kilogram body weight. And the second sentence is it should not be given round the clock. So I could not understand this.
I want to tell that it should be used only in bolus form, when you are seeing features of raised ICT, generally what we see a prescription where IV mannitol 8 hourly is written and it is followed that ways. I don't feel it should be written in that way. You should clinically see, the intensivist should clinically see the patient, and only when there is a frank raised ICT, that moment it should be given in bolus form. Using it
2 grams at a time, 2 grams per.
Yeah. But it should not be used round the clock because the chances of renal injury increase significantly. Yes, sir. Sorry, I didn't go. Yeah.
Ejection fraction is depressed below 40. What should my approach? Because of mannitol, I will give the kidney injury will be more deteriorated. And then in case of the 3% saline, I will give the heart function has been impaired. What will be my approach in this patient management?
So actually, I would not like to have such a patient because acute liver failure with cardiac is the worst subgroup. They are never going to do well. This is the common scenario which we see in this rat killer poison, because rat killer poison commonly has a myocardial involvement. The prognosis is dismal in this patient. It is really very difficult to manage the patients. I think so. A good intensivist is a key who will really look at the hemodynamics. Maybe there are some things like PICO or some advanced hemodynamic monitoring systems which can be inserted and managed. But this is a category, I agree to you. It is very, very difficult to manage, and generally they will have dismal prognosis.
Sir, can I ask second question?
Yes, please.
Patient has acute liver failure. Patient raised, because I am neurologist, I have asked regarding renal. Patient has a raised ICT. You have give advice regarding the not use the midazolam. But we can use the lorazepam in place of the midazolam.
Sir, acute liver failure is one entity where we should use less sedation drugs which have metabolism through the liver. So benzodiazepines unfortunately have lot of metabolism through the liver. And one of the important criteria which I showed in the ALFED model is monitoring the hepatic encephalopathy grade over 72 hours. If we are giving midazolam or benzodiazepines, lorazepam kind of drugs, this monitoring really gets hampered. I still feel as much as possible try to use propofol. Propofol also has a very good anti-epileptic action, and prophylactically we should institute anti-epileptic drugs. Pre-transplant we have studied a lot. Phenytoin is a very good drug to use. Post-transplant definitely we tend to use levetiracetam more, but I would make it maybe like that unless pushed to the wall and we have no option, we should not use benzodiazepines. But there are some situations where we are really pushed to the wall and we may have to use. Leaving that indication, we should really not use benzodiazepines commonly.
And sir, regarding anti-epileptic drug, first, until seizure, I will not give the anti-epileptic prophylactically in case of the acute liver failure patient. If I will try to phenytoin or I will try to levetiracetam.
So there was a study in this by All India Institute only. What they recommend is any patient with grade 3 encephalopathy or higher, even without seizure, you should prophylactically institute anti-seizure treatment. Pre-transplant, All India Institute has studied the data, and I think so we should regard that data because it is really well done data over hard work of 10 years. They have shown that phenytoin use in grade 3 or more encephalopathy in acute liver failure without transplant is absolutely safe without any problem. So I think so phenytoin, easy to use, we all are very comfortable using it, should be used in pre-transplant, grade 3 encephalopathy or above. Post-transplant, levetiracetam.
And sir, additional drug of what role of the lamotrizine we can use in the liver failure patient or gabapentin? Have you, sir, any idea?
Sir, sorry to interrupt, but please give a chance to other delegates. You can ask the question later.
Cerebral edema due to the cerebral malaria and
so that's what I told you, sir. This tropical fevers, identifying them is the most important thing. Because generally malaria with cerebral edema, it will respond very well to anti-malarial treatment. hepatic encephalopathy will not respond to anti-malaria treatment. I think so. Diagnosing that this is malaria and then this is multi-organ involvement due to malaria rather than a true acute liver failure is the most important thing. That is the best thing. I don't think so clinically, rather than response to treatment and diagnosing it at the first step, that this is not acute liver failure truly, but it is malaria related. Multi-organ involvement is the most important thing, sir.
Is there any comments from the chairpersons? Please welcome.
Thank you. Thank you for excellent lectures.
Yeah.
Okay.
Thank you.
Thank you, Dr. VINIT SHAH, for giving the audience in-depth knowledge about the presentation, evaluation, and perfect management of the acute liver failure patients. So I would like to request Dr. Shashank Paswala to please felicitate Dr. VINIT SHAH. Dr. Shashank Paswala. So, Dr. Shashank Paswala is not here, so I would request Dr. SAUMIN sir to please felicitate Dr. VINIT SHAH. It was a fantastic and interactive session. Thank you very much.
So let's move forward to the next session on acute kidney injury in cirrhosis of liver by Dr. NEERAJ SARAF. Is one of family member of Dr. NEERAJ SARAF is got infected with COVID. He is not available here, so we'll listen to him on online platform. Dr. NEERAJ SARAF is a director at Hepatology and Gastrology Department in Institute of Digestive and Hepatobiliary Science, Medanta Hospital, Gurugram. I would request chairs Dr. Keyur Thakur, Dr. Mukul Vyas, Dr. Kalpesh Joshi, and Dr. Pawan Agarwal to please come on the stage. So, what is yours, Dr. NEERAJ SARAF?
Am I visible and my slides visible?
Yes, yes.
And am I audible too?
Yes, clearly audible, sir.
Okay, thank you. So first of all, my apologies for not being there physically. I think till day before yesterday, I was planning to come, but there were multiple people in my family with COVID, and I was exposed, and a lot of uncertainty. So I requested SAUMIN to let me talk online, and he kindly agreed. So thank you, the organizers. Thank you, SAUMIN, for inviting me here. And in the next half an hour or so, I'll talk of acute kidney injury in liver cirrhosis. So these are some of the things which I will try and cover. How do we define acute kidney injury? What is the classification? What are the types? What are the causes of acute kidney injury? Specifically, I'll talk of hepatothenal syndrome because that's probably very relevant when we talk of end-stage liver disease. I'll talk a little bit of pathophysiology, and then, of course, management of AKI in general and management of hepatothenal syndrome. And I'll talk a little bit of liver transplant, what happens to liver transplant when a patient with cirrhosis has AKI. Can we do a liver transplant, and what are the conditions in which we need a liver plus a kidney transplant? So why are we discussing this topic? So why are we discussing this topic of acute kidney injury in liver cirrhosis? Well, if you look at this paper published in Journal of Hepatology almost 10 years ago, there's a significant deterioration and decreased survival of hospitalized patients if they have acute kidney injury. So if you look at this graph, patients who have no kidney injury, the 90-day survival is 88%. And as the kidney injury starts and as it worsens, and if you can look at the lowest line, severe grade of AKI, and I'll talk of all these grades also in the next few slides, the survival falls to as low as 31%. So acute kidney injury in a patient with liver cirrhosis has huge survival implications. It has huge prognostic implications, and I'll talk of that again also, that AKI can lead to chronic kidney disease as well. So this is one of the the biggest clinical problems we face as hepatologists in a liver unit, and especially in a liver transplant unit, where it becomes very difficult to take a patient up for transplant if they have kidney injury. So I'll sort of run through a case and take you through the talk, discussing a small case. So this is a patient who, Mr. YS, 51-year-old male. He's a resident of Haryana, and he's been a known case of Nash-related cirrhosis for the last 4 years or so. He's diabetic, he's hypertension, and he's had decompensation in the form of ascites and hepatic encephalopathy. So this is the timeline of events of this patient. He was diagnosed to have Nash-related cirrhosis in 2018. He was compensated at that time. In 19, he developed some ascites, which was diuretic responsive. He had banding done for varices. In 20, about a year later, he had one episode of hepatic encephalopathy as well, and continued to have some ascites. In January 21, he started needing recurrent large volume paracentesis for his ascites, and he also developed acute kidney injury, which at that time we had called it hepatothenal syndrome, and I'll talk about the definitions soon. But his creatinine came down to 1.4, but he still had a slightly higher creatinine than normal, even with all the treatment. So in July 21, he came to us with gross ascites, a rising creatinine of 3.6. So this is his labs when he came to us last year in July. His INR is 1.6. Creatinine, as you can see, is 3.6. So it has gone from a baseline of about 1.4 to 3.6. Bilirubin is 1.6. He has a low albumin. Urine spot sodium is low. Rest of the urine routine is normal. You can see that there is some proteinuria. Again, probably I think he has some degree of diabetic nephropathy, and which again has implications when we talk of management of AKI. So we have a patient who is decompensated, presented to us with gross ascites, needing recurrent LVP, and now has acute kidney injury with a creatinine of 3.6. So let's come to the grading of renal dysfunction in cirrhosis. So how do we, classify renal dysfunction in cirrhosis? So there are 3 different categories: acute kidney injury, acute kidney disease, and chronic kidney disease. And my focus, as requested by the organizers, will today be on acute kidney injury. So how do we define acute kidney injury? So acute kidney injury is an increase in serum creatinine of more than 0.3 milligrams per DL within 48 hours, or a more than 50% increase from baseline value in the last 7 days, or a decrease urine output less than 0.5 ml per kg body weight over a period of more than 6 hours. So this is how you define acute kidney injury: increase in absolute value by more than 0.3, or increase in 50% from the baseline value. And I'll talk about what is baseline value also in the next slide. Acute kidney disease is defined as GFR less than 60 for less than 3 months, or a decrease in GFR by more than 35%, or an increase in serum creatinine by more than 50% for less than 3 months. So if you can see, AKI and AKD, the difference is basically between the timing. So if it's within 7 days, it is acute kidney injury. But if it is a gradual process up to 3 months, then it is acute kidney disease. And what is chronic kidney disease? If it's almost the same thing, but if it persists for more than 90 days. So this is the spectrum of renal dysfunction and in cirrhosis, and I'll talk of mainly of the first one, acute kidney injury, in the next few minutes. So how do we define acute kidney injury in cirrhosis? So this is the definition, the latest definition given by the International Ascites Club in 2015. So a value of serum creatinine obtained in the previous 3 months when available can be used as a baseline creatinine. So any value which we have in the last 3 months can be used as a baseline. In patients where more than one value within the 3 months is available, then the value closest to the admission time to the hospital should be used. So that is what we define as baseline creatinine. In patients without a previous creatinine value, the serum creatinine on admission should be considered a baseline creatinine. So this is how you define baseline creatinine. And now how do we define AKI? Well, I just told you in the previous slide also. So an increase in serum creatinine more than 0.3 within 48 hours, or a percentage increase of more than 50% from baseline, which is known or presumed to have occurred within the prior 7 days. So there's absolute increase and there's a percentage increase, and I just defined for you what is the baseline creatinine mean. Now, this is AKI, but how do we stage AKI? So stage 1, which is the milder form, there is an increase in serum creatinine of more than 0.3 or increase in serum creatinine more than 1.5 to 2-fold from baseline. In stage 2, there is an increase in serum creatinine greater than 2 to 3-fold from baseline. And in stage 3, there is an increase in serum creatinine 3-fold from baseline, or an absolute serum creatinine value of more than 4, with an increase of more than 0.3 or initiation of renal replacement therapy. So these are the stages of AKI, stage 1, 2, 3, and basically it just goes from a lower creatinine value to a higher creatinine value. Now, progression of AKI to a higher stage or need for renal replacement. So when we say AKI is progressing, that means it's going from stage 1 to 3, or a patient is needing renal replacement. And regression is obviously the opposite, that it is coming to a lower stage. So these are some of the definitions which were given by the International Ascites Club. And what I want to highlight is, I think what has changed in the last decade or 2 decades is why have they, chosen a value of 0.3 and just a 50% rise? Because the idea is to call it or label it AKI early rather than late, because it has implications. If you keep waiting, for example, earlier it used to be creatinine, a baseline, absolute value of 1.5. So if you keep waiting for the absolute value to be reached, then sometimes you may be too late in treating that patient. But now with this definition, if a patient has a creatinine of 1 and he goes to 1.3, then you call it AKI and you start treatment. So you detect it early and you start treating early. So this is just again the same thing which I told in the last slide, a pictorial form, absolute increase in creatinine of more than 0.3 in 48 hours. And this is you can see the time frame, and AKI is defined as percentage increase in more than 50% in last 7 days from the baseline creatinine. So these are the definitions of AKI. Now, what is, how common is AKI? So I told you why AKI is important, because it has implications in outcome. I've given you the definitions of AKI. Now, what is the percentage of patients who have AKI in a hospital setting? So this is a study published in Gastroenterology about 10 years ago, 463 patients of cirrhosis with AKI, and they saw that almost half of the AKI was because of infections. 1/3 was because of hypovolemia, and about 13 to 15% was because of hepatothenal syndrome. So although hepatothenal syndrome is something which we are all dread, and I'll talk of that probably a little more because that is directly related to cirrhosis. The more common causes of kidney injury in cirrhosis are infections, and hypovolemia. And that is our, clinical experience also. And I'm sure my colleagues sitting here will agree that probably infection and hypovolemia is the leading cause of acute kidney injury in patients with liver cirrhosis. So these are the various causes of AKI in cirrhosis. So you can have pre-renal azotemia, you can have ATN, hepatothenal syndrome, acute interstitial nephritis, acute glomerulonephritis, and then you can have CKD, which is sort of overlapping with acute kidney injury. And a lot of times we see patients who have acute on chronic kidney disease. So they have underlying chronic kidney disease, and then they develop an acute injury on that as well. So this is the spectrum of AKI in liver cirrhosis. Now, the spectrum, it can be functional or structural. The functional is volume responsive. Generally, it is pre-renal or sepsis related. Volume and structural is generally volume non-responsive. Now, we have various tools to decide whether the injury is functional or structural. So history and clinical examination, history of nephrotoxic drugs, volume loss, active urine sediment, urine proteins, fractional excretion of urea, fractional excretion of sodium. These are all labs which you can use to decide between a functional and structural acute kidney injury. And there are some biomarkers available, and I'll talk a little bit of that subsequently. So what is the pathophysiology of organ failure, which includes renal dysfunction in patients with liver cirrhosis? So there is basically a portal hypertension, there is bacterial translocation, a PAMP release, activation of innate host immunity, release of reactive oxygen species and pro-inflammatory cytokines, causing splanchnic arterial vasodilatation, inadequate cardiac output, leading to various complications, including renal dysfunction. So this is the key when we talk of renal dysfunction, splanchnic arterial vasodilatation, which occurs because of portal hypertension. Now, when we talk of acute kidney injury, like I said, one of the causes is hepatothenal syndrome, and the others are pre-renal or ATN. Sometimes it's very difficult to differentiate between the two. And most of the times, hepatothenal syndrome is a diagnosis of exclusion. So you do imaging, you do look for proteinuria, you look for active sediment, you can look for markers of structural damage like NGAL, fractional excretion of sodium, fractional urea. And once we have done all these tests, I think a lot of these are theoretical. We really don't do them in practice. Then only we can define a patient as having ATN or HRS. But I think a lot of times it is mostly a clinical, and by probably giving some fluid challenge, and I'll talk of that again, based on which we decide whether a patient has ATN or hepatothenal syndrome. So pre-renal AKI is generally hypovolemia caused by gastrointestinal fluid loss, renal fluid loss, GI bleed, a very common cause of pre-renal acute kidney injury. It's usually volume responsive and resolves within 48 hours with withdrawal of diuretics and volume expansion with colloids or crystalloids. Intrinsic AKI or ATN is generally because of sepsis, probably a most common cause, again because of drugs, acute glomerulonephritis, sometimes vasculitis, and you have features of active urine sediment, proteinuria, and casts. So we've talked of the various aspects of pre-renal, which is responsive to fluids, ATN, mostly caused by sepsis and drugs. And then the third and probably very relevant to us is hepatothenal syndrome. Now, hepatothenal syndrome has seen a sea change in its definition in the last 2 decades. So in the late 90s, there used to be a different definition of HRS, where they went by the absolute value of serum creatinine, which was more than 1.5. And then they had some minor criteria. So they had major criteria, minor criteria. And this is, when I was studying gastroenterology in the early 2000s, This is what we used to follow, major and minor criteria to diagnose HRS. In 2007, the International Ascites Club got done away with minor criteria, and we had only one set of criteria. Again, the absolute value of creatinine was important. That means a patient had to have more than 1.5 creatinine. He had to have absence of shock, absence of hematuria, absence of proteinuria, normal kidney on ultrasound, and no improvement in kidney functions after 2 days of volume expansion with albumin. So this is a key point, that if a person does not respond after 48 hours of volume replacement, then that goes in favor of hepatorenal syndrome. So in 2015, what happened? Most of the things remain same. The absence of drugs and hematuria and the volume expansion criteria, but they have done away with the absolute value of creatinine of 1.5. And so what is the latest definition of HRS? This is that a patient needs to have cirrhosis or acute liver failure or acute on chronic liver failure. There has to be an increase in serum creatinine of more than 0.3 or more than 50% from baseline in 48 hours. This is just like what I told you for AKI. No response to diuretic withdrawal and volume expansion, no current or recent nephrotoxic drugs, absence of parenchymal disease, absence of proteinuria, hematuria. So all the other criteria remain same. So basically, what is HRS? It is AKI. It is a form of AKI which is non-responsive to fluids. So most of the definition of HRS is same as AKI, with a lot of don'ts or no's, and which are absence of shock, absence of drugs, absence of parenchymal disease. So HRS is a form of AKI, and now it is commonly called as AKI HRS. So AKI-HRS is the terminology which we use now when we define a patient of liver cirrhosis with hepatorenal syndrome. So this is the new classification of hepatorenal syndrome. So on your left is the old one, which is HRS 1 and 2. And now we have the new definition, which I just told you it's called HRS AKI. And the criteria I have just told you again, same absolute increase in creatinine, more than 0.3 and more than 50% increase from baseline. So this is a hepatorenal syndrome, AKI. And this is what I'll be talking about, because my talk is on acute kidney injury. The other HRS is HRS non-AKI, which is HRS AKD and HRS CKD. So it's the same thing which I've told you earlier, the definitions of AKD and CKD, which are time framed. So if it's within 3 months, it is called HRS AKD, and if it's more than 3 months, it is called HRS CKD. But this is what we see mostly in clinical practice, HRS AKI. And this is the new classification of hepatorenal syndrome, which corresponds to the old definition of hepatorenal syndrome type 1. So what is the pathophysiology of hepatorenal syndrome? Well, it's basically increased renal sodium, decreased capacity to secrete solute-free water, hyponatremia, decreased GFR. So effectively, it is splanchnic vasodilatation causing decreased effective circulatory volume and increase in the RAS and causing renal dysfunction. So the kidneys structurally are normal. It's a functional disorder because of the portal hypertension and the increase in pro-inflammatory cytokines. Recently, it has been seen, there's some studies which show that in the mechanism of HRS AKI, there is renal hypoperfusion. We've known that for decades. There is microvascular dysfunction, but now there's some data to suggest there may be some tubular damage as well. So it may not be entirely functional. There may be a structural element to it. And this is a new concept, and this is a study which was published last year in Journal of Hepatology. I think I've already spoken of this, HRS, AKD, and CKD, and that's not going to be, what I'm covering today. So when we assess a patient of, non-AKI, then again, we must know the baseline creatinine, the GAFR, and again, we must have imaging, urine microscopy, risk factors for chronic kidney disease, and a kidney biopsy if possible. Again, this is assessment of acute kidney disease, which is of a longer duration than acute kidney injury. So how do we manage acute kidney injury in a patient of cirrhosis? So like I said, the commonest cause is probably pre-renal or infections. Pre-renal, I think, is at least 1/3 of all AKI in cirrhosis. So appropriate volume expansion is done and with the choice of albumin, which can be 5% or 20%. Crystalloids can also be used like plasma-lite or normal saline, and sometimes it may be better to use a combination. What we have to be careful in cirrhotics is that the patient should not go into fluid overload. We should assess the volume by fluid responsiveness, dynamic indices. Earlier it used to be CVP. Now most of the times we can do ultrasound and look at the IVC collapsibility. So if the IVC is collapsible, it means the patient needs more fluid. Our ICU people now use an echo to look at the ventricular filling to decide whether a patient has a fluid requirement or not. And the target of replacement is generally mean arterial pressure, urine output, lactate, and sometimes ultrasound or echocardiographic findings. So choice of fluid in sepsis-induced hypotension, again, it depends on the clinical scenario, but you could use crystalloids or colloids, and 5% or 20% albumin can be used, or a solution like plasma-lite or normal saline can be used. But again, I want to highlight, it is important that to make sure that the patient does not go in fluid overload, because this is a common problem with cirrhotics. Coming to management of ATN, well, ATN, again, it's a lot of times is sepsis-induced or drug-induced, and the treatment is obviously remove the offending drug, the infection. But what is important when we talk of ATN is the clinical presentation and the timing. So it is important to detect ATN early and treat it early, because ATN, if left for too long, then the functional recovery is low and it leads to chronic kidney disease. Of course, if there are certain criteria defined, which I think all of you know, which are indications for hemodialysis. So these are some of the drugs causing nephrotoxicity, which we use in cirrhotics. Antibiotics like aminoglycosides, vancomycin, antifungals, immunomodulators in the post-transplant setting, calcineurin inhibitors, antivirals, ACE inhibitors, again, commonly used in cirrhotic patients, can cause nephrotoxicity and lead to acute kidney injury. So this is how we approach a patient of acute kidney injury. So if a patient has stage 1 AKI, we closely monitor him, remove the risk factors, withdraw nephrotoxic drugs, give volume expansion. If it resolves, then just keep a close follow-up. If it's stable, then you decide case by case. But if it progresses to stage 2 or 3, then if a patient has not responded to volume expansion, then he probably meets the criteria for hepatorenal syndrome, and then vasoconstrictors and albumin can be tried in the treatment of hepatorenal syndrome. So coming back to our patient, he had Nash-related cirrhosis, portal hypertension, he had refractory ascites. He was not tolerating diuretics, so we had not been giving diuretics, so there was no drug-induced renal dysfunction in this patient. We gave him a volume challenge with albumin for 48 hours. He did not respond. So based on the criteria of his duration and of absence of urine segment, absence of responsiveness to fluid, our diagnosis was that he has AKI HRS. I think he probably had an element of diabetic nephropathy as well, which probably made things worse. So this patient has AKI HRS and has a CTP score of 9 and a MELD sodium score of 29. I'll come back to the patient a little later. So we have diagnosed that the patient has hepatorenal syndrome. Now let's talk of management of hepatorenal syndrome. So the cornerstone of pharmacological treatment for HRS is the use of vasoconstrictors with a goal-directed approach to target a rise in mean arterial pressure by 15 or to reach absolute MAP of more than 85. So as the kidney function declines and the serum bilirubin increases, the likelihood of successful reversal of HRS with vasoconstrictor decreases. So early recognition of HRS is therefore critical to initiating therapy. And again, I want to go back to, and that is why the definitions have been changed. The threshold for diagnosing HRS has been made lower because it has been seen that if you diagnose it too late, then the reversibility of HRS gets extremely low. But if you diagnose it early, use vasoconstrictors like terlipressin early, then the reversibility is significantly more. So this is the vasopressors which are used in hepatorenal syndrome, most commonly terlipressin. You can give 0.5 milligrams every 4 to 6 hours, increase to 1 milligram every 4 hours, and then even 2 milligrams every 4 to 6 hours. Or you could give an intravenous continuous infusion, and I'll talk of that in the next few slides. The other options are midodrine and octreotide, but studies have shown this is not as effective. And noradrenaline can also be used in patients who are intolerant to terlipressin. Most studies which compare terlipressin and noradrenaline are similar, similar results, and noradrenaline is also, I think, reasonably good in treating hepatorenal syndrome. Duration of therapy is generally between 5 to 15 days. And if a patient is not responding to vasoconstrictors, then I think we need to consider other aspects like TIPS or the liver transplant. So these are some of the studies which have been published in the last couple of decades on management of HRS with terlipressin. And as you can see, the study by Alexandria et al. 83% had HRS reversal. Martin Lei, again, a very important study, 44% had reversal and 27% had survival. Study recently by Kavalin et al. Again, 70% had HRS reversal, and significant patients survived short term after using terlipressin. So terlipressin plus albumin in various studies has shown to improve or reverse HRS to the tune of almost 70% of patients. This is a recent study published in NEJM last year, again using terlipressin plus albumin for hepatorenal syndrome. So this is a randomized controlled trial, terlipressin versus a placebo. And again, if you see the primary endpoint, which was reversible of HRS, was significant, 0.06. Clinical success was significantly higher in terlipressin, 63 patients versus 17 patients in the placebo group. But they also saw that the terlipressin group had higher complications, especially related to the lung and heart. So everything comes at a price, but terlipressin plus albumin is extremely effective in treating hepatorenal syndrome. Now, this is a concept which has come in the last few years, and we have shifted entirely to terlipressin infusion. So this is a study published in 2018, I think, in Hepatology. 78 patients got the infusion, 2 milligrams per day, and a similar group got 0.5 milligrams every 4 hours. And if you can see in the bolus group, the survival in the responders were significantly higher in the infusion group as compared to the bolus group. And what is more important, I think, is that the tolerance to infusion is much better. The side effects which we used to see with bolus, like peripheral ischemia, abdominal ischemia, abdominal pain, diarrhea, they are significantly better when you use infusion rather than a bolus, and this was shown by this study in hepatology. So again, a list of studies showing vasoconstrictors in HRS. Various combinations have been tried, terlipressin alone, noradrenaline, midodrine, but the best results have been with terlipressin plus albumin. And like I said, there's been almost a 70% reversal in hepatothenal syndrome with this combination. Another study which came out in Lancet in a few years ago, this is a study which was done in decompensated cirrhotic patients who were given long-term albumin, so they were given weekly albumin. So the aim of this study was actually to see if albumin improved survival, but one of the aims was, one of the things which was seen in the study was that renal dysfunction with creatinine more than 1.5 and hepatothenal syndrome, the standard medical treatment plus human albumin was better than standard medical treatment alone. So even in the long run, patients who got weekly albumin had improvement and better kidney profile than those who did not. So this is something which, again, we are using a lot now in patients who had hepatothenal syndrome. We keep them on home albumin weekly, and we've seen that it helps maintain the kidney functions.
Sir, 2 minutes.
Yeah, I'll just end in a couple of minutes. So again, this is an editorial published in Journal of Hepatology about acute kidney injury. So AKI not only has immediate survival implications, but it also causes chronic kidney disease. And this is a recent study which showed that patients who had more worse stage of AKI had significantly higher CKD as compared to those patients who did not have AKI or had milder forms of AKI. So recurrent AKI or a higher stage of AKI can lead to chronic kidney disease in almost 1/4 of the patients. So again, importance of why we should treat AKI. So coming back to our patient, he was given albumin plus terlipressin. His creatinine improved from 3.6 to 2.5. But then, subsequently in a few weeks again, went up to 4.1. We could not maintain it even with home albumin, and his creatinine increased to 4.1. He had a eGFR of 18 and he had gross ascites. So what do we do now? Well, TIPS is out, I think, because with such a bad AKI, TIPS we have seen doesn't work. He's also had encephalopathy, so TIPS is not going to be helpful. So we offered him a liver transplant. Now the question is, can he go for a liver transplant or does he need a liver plus kidney transplant? So just last couple of slides. So patients who have AKI for more than 4 weeks, patients who have stage 3 AKI with a 3-fold increase in serum creatinine from baseline, and patients who have eGFR of less than 35 for more than 4 weeks, the recommendations are to go for a simultaneous liver plus kidney transplant. So this is what our patient had. He had, I think, about 2 months of AKI, which was stage 3, not responding to vasoconstrictors, had a GFR of 18, and so he was not really a good candidate for liver transplant alone. And we did a simultaneous liver kidney transplant for this patient. Again, just to show you the indications for simultaneous liver kidney transplant. So end-stage liver disease, GFR less than 30, and if the GFR has been less than 30 for 4 to 8 weeks. So it's the timing. So if the GFR is less than 30 for a week and it improves, that's not an indication for liver plus kidney transplant. But if it's been there for 4 to 8 weeks, then you should go for a liver plus kidney transplant. Other indications for the combined transplant are proteinuria or chronic kidney disease. But if you don't have them, then a patient can go for liver transplant alone. So our patient fulfilled the criteria of low GFR for more than 4 to 8 weeks, not responding to medical treatment, and hence was a candidate for a simultaneous liver plus kidney transplant. So he underwent a SLKT. He had donor issues earlier, but so he had a kidney donor, living donor, and he fortunately got a cadaver liver donor at one of our peripheral centers. So we did a combined transplant in him using a living donor kidney and a cadaver liver, and it's been about 7-8 months, I think, and the patient is doing well. I think I'll skip this. This is just a summary of what I've just said. So the take-home message is that AKI is common in cirrhosis. It adversely affects outcome. New definitions are aimed at detecting AKI early and treating it early. It is important to rule out all causes of acute kidney injury before labeling a patient as hepatothenal syndrome. Creatinine and eGFR are still probably the most practical tests to assess AKI. Biomarkers, I think I didn't talk about it, like cystatin C are ideal but still not widely available. Fluid replacement, albumin is generally the first line management of AKI, and to to rule out hypovolemia and to call it hepatothenal syndrome. Vasoconstrictors are the key drugs to reverse hepatothenal syndrome. Terlipressin infusion is effective in HRS reversible with better tolerance as compared to bolus doses. AKI can lead to chronic kidney disease, hence it's important to identify the cause of AKI and treat it early. Hepatothenal syndrome, I must say, is even if a person reverses hepatothenal syndrome, it is generally temporary, and a person, any patient with hepatothenal syndrome should be evaluated for liver transplant. And patients who don't meet the criteria for liver transplant alone have had low GFR for more than 4 to 8 weeks should be offered simultaneous liver plus kidney transplant. Thank you.
Thank you, Dr. NEERAJ, for such an illustrative lecture on AKI in cirrhotics. Now I open the house for questions. We can just take 2 questions because of the paucity of time.
So, is there any question?
Hi, sir. SAUMIN here. Thank you. And hope for the speedy recovery for your family member. So, this is a physician forum and most of them are physician. So, I think when patients, suppose comes with cirrhosis and admitted with creatinine suppose 1.2 and GFR is calculated, it is hovering around 70. So should we suspect that it is means it is already in HRS, or we have to absorb for 6 hours or 1 day and repeat the creatinine and then start treatment?
Yes, so that's what, so absolute value. So if his baseline creatinine is 0.6 and now it has become 1.2, then he has acute kidney injury. But if his baseline is 1 and if he has 1.2, then I don't think it is acute kidney injury. So it's the increase from baseline which is important and not absolute value of creatinine. So if the baseline is 1.2 and he comes to you with 1.2, I don't think we should be too worried. But yes, if there is an increase, then definitely we need to treat him as AKI and treat accordingly and find the cause and then manage him.
So just means crux, if patient baseline creatinine is 0.6, but it will convert to the 0.1 or 1.1, till you should consider it's maybe a HRS.
Yes, yes, definitely.
So
that is the key message, that it is not the absolute value. So if a person goes from 0.6 to 1.1, 1.1 may be within the normal range of your lab value, but then he still has AKI.
So that's what Dr. NEERAJ told rightly. The dynamicity in creatinine is the key. I think so. Even 0.6 to 0.9 is AKI.
Yes.
And please, liver cirrhosis with AKI doesn't mean HRS always. That is the very important thing, because as sir also showed, more than 60 to 70% are in fact due to volume responsiveness, and they are not HRS. So every patient with cirrhosis who comes with acute kidney injury is not HRS. That is, I think, so very important.
I think if I want to give 2 messages, it will be the definition that, like Vinit said, it is the dynamicity. You have to detect it with the percentage increase and call it AKI early so that it can be treated early. And the second message is not every kidney injury in cirrhosis is HRS. And like and that's what VINIT said, and I showed in my slides, 15 to 20% of all AKI. Most of the times it's sepsis and hypovolemia, and just by giving them volume with albumin or plasma light or normal saline, most of the times you can, improve these patients. So we should not jump to using, terlipressin or midodrine in all patients with AKI till we have shown that they are non-responsive to fluids.
Sir, second means the recent change of classification. HRS 1 to 2 to HRS AKI, HRS non-AKI, and then AKD, CKD. What are the major difference? Why there are so much classification?
So actually it's simple now. So first of all, there are no major minor criteria, and it's all time duration. So HRS is a type of AKI. So if you have AKI, which is non-responsive to fluids, does not have any structural issue, no proteinuria, no ultrasound problem, you just call it HRS. And so it is HRS AKI. And this is within 48 hours or within 7 days, 50% rise in creatinine. If it's 7 months, then you call it HRS acute kidney disease. If it is more than 3 months, it is HRS CKD. So it's a time. So it is not really complicated. It's very simple. In fact, that is what they've tried to do. Make it more simple. So it's basically AKI and AKI.
Anybody wants to ask anything?
Hi, sir. So basically, the definition of AKI that they have been given is the rise of more than 0.3 milligrams per deciliter in next 48 hours. But when if the patient is already in hepatothenal syndrome, means jaundice, if there is bilirubin also increasing, the methods used to measure creatinine, most of the labs, they don't use IDMPS method, or that is isotope dilution mass spectroscopy. Most of them use HPLC. And then there might be this confusion because bilirubin might interfere with the creatinine measurement even after the correction for the dilution. So this absolute value of 0.3 milligrams per deciliter rise in 48 hours. I mean, how far is it justifiable, or after correction, is it all okay to do with that? Thank you.
Yeah, so you have a valid point, and I didn't, because of lack of time, I didn't touch upon biomarkers. So probably, yes, creatinine is not the ideal test for patients in cirrhosis for the reasons you said about the, the bilirubin interfering, the type of thing, method. And plus, most of the cirrhotics have very poor muscle mass, and they may not even show an adequate rise in creatinine. So another small molecule which is secreted by nucleated cells, cystatin C, has been shown to be the ideal marker for kidney injury in cirrhosis. But again, it's not really widely available. Even, we don't use it. There's not still enough validation data on cystatin C. I think till that time, creatinine generally works. I agree it is not ideal, but I think most of the times it gives you a fair idea of which way the patient is progressing. And like, I said, Vinit also said, it's a dynamic situation. So it is the rise and the fall which are important, and not really sometimes the absolute value.
Any questions? Any more questions? Any comments from the chairs? So thank you, Dr. NEERAJ SARAF. It was really an insightful session on AKI in cirrhosis patient. So please accept our felicitation from Gujarat Gastro Hospital and Association of Physicians, Surat. Thank you, Doctor.
Thank you. Thank you for inviting me, and my apologies again for not being there physically. I will definitely be there next time.
We
hopefully.
missed your physical presence, sir.
Thank you.
So moving towards our next session, tuberculosis still remains a major global health problem despite the availability of higher effective treatments. And hepatotoxicity is the commonest adverse effect which may lead to drug discontinuation, and that may in turn increase the morbidity. So to throw more light on this subject, we have today Dr. Mithun Sharma, and the topic is anti-tuberculous treatment-induced hepatitis. So I would request Dr. Mithun Sharma to please come on the stage, and I would also request the chairs for this session, that is Dr. Kanti Patel, Dr. Bhavikant Chaudhary, Dr. Devang Desai, Dr. Jayesh Shah, and Dr. Sandeep Bhagat. So Chairs, please come on the stage. Please take your positions. And I would request Dr. Praful to introduce the speaker.
Dr. Mithun Sharma, he is the Director of Hepatology, Regenerative Medicine and Liver Transplant Department of Asian Institute of Gastroenterology and AIG Hospital, Hyderabad. He has numerous publications and are peer-reviewed and is national and international journals. He is member of ASLD, ESL, American College of Gastroenterology, INASLs, and other various boards. The stage is yours, Dr. Mithun.
Thank you so much for the introduction, and I'm the last man standing with the lunch almost ready, so I'll be trying to be short here. So tuberculosis is an age-old disease, but when I went through literature, we have so many physicians who will know this subject better than me. So, but the treatment is not so new. It started from 1944 and rifampicin in 1963. Whereas this picture is of depicting a tuberculosis which has been reported almost close to 9,000 years ago in the city called Yam City, which is under the Mediterranean Sea near Israel. So when we talk about treatment of tuberculosis, there has been recent progress. But what I'm going to talk today is about ATT-induced hepatitis, or a more logical term will be anti-tubercular therapy-induced, drug-induced liver injury. So this is the outline of my presentation. I will briefly outline what is drug-induced liver injury, how do we diagnose it, the drug-induced liver injury status in India, ATT-induced DILI, how do we manage them, how do we reintroduce them, and how we give ATT in patients who have liver cirrhosis. So when I was doing my medicine, I remember coming to listen to a talk by Dr. Premashish Kaur, who is a hepatologist in Delhi. And my expectation was that he will give me a flow chart and I will follow it in my patients. And I was very upset at the end of the talk because he gave a lot of literature, did not give much of guidelines. But today when I prepared the talk, I realized actually there is no specific guidelines from India, and most of the guidelines are American and British, and I'll go through that in a short while. So when do we call it as a drug-induced liver injury in the setting of anti-tubercular therapy? So most people use these criteria: an ALT of greater than 5 times of the upper limit of normal, or greater than 3 times of upper limit of normal, coupled with a bilirubin of more than 2 times, or if it is more than 2 times and the alkaline phosphatase also is high and the source is liver. So the DILI is a diagnosis of mostly exclusion. So it depends on the time of onset, what were the clinical presentation, what was the recovery, what were the specific risk factors, and we exclude other diagnoses. And the most convincing evidence of a drug-induced liver injury is that it should recur when there is a re-challenge, but re-challenging is not always safe and not always an advisable thing. So we have to keep in mind these 3 things here. One is the R value. I'll come to this in the next slide. R value tells us what is the type of liver injury. Then there is something called the Hy's law, which is named after the physician who devised it. So if we see a patient whose ALT by AST is more than 3, bilirubin of more than 2 times of the upper limit of normal, without any other findings of cholestasis like a raised alkaline phosphatase, and we attribute this reason to drug-induced liver injury, there is a mortality of 1 in 10. And then if the recent all papers, you will see a scoring system which is called RUCUM score, which is very tedious to do in clinical practice, but is required for any publications on drug-induced liver injury. So when you talk of drug-induced liver injury, based on the clinical presentation, it can be either intrinsic or idiosyncratic. Based on the pattern of enzyme elevation, it can be either hepatocellular, cholestatic, or mixed. And if we have done a biopsy, it can tell us about granulomatous, cholestatic pattern and all. So idiosyncratic drug-induced liver injury are mostly unpredictable. It is independent of the dose, and they have a long latency period. And in humans, there are only few drugs which cause an idiosyncratic DILI. Intrinsic are mostly predictable, they are dose dependent, the latency period is not that long, and it is very high prevalence or attributed in humans. So again, if we talk about idiosyncratic, it can be immune mediated and non-immune mediated. In immune mediated, we see that there is associated fever, rash, and eosinophilia, and there is a very high chance of re-injury on re-challenging with the drug. So why does a drug cause a liver injury? So a drug causes liver injury not because of the drug itself. It mostly is caused due to the reactive metabolite. This metabolite, which is intermediate between the drug and the end product, can lead to an abnormal endothelial stress. It can covalently bind with many molecules, and it can cause stress kinase activation. This is coupled with our glutathione system, which is considered to be protective. If there is abnormality in that, it can cause a liver injury. Based on how much each of this is there, it can be either a lethal, which is mostly intrinsic, or it can be an adaptive response. Whenever we take, for example, statins, some amount of AST, ALT elevation is expected. That is an adaptation reaction. Or it can be an idiosyncratic. So what we'll talk today is drug-induced liver injury due to anti-tubercular therapy, and most of them are idiosyncratic, and most of the common pattern is usually hepatocellular. So every drug that causes a liver injury has a particular signature pattern. For example, some drugs will cause an autoimmune hepatitis-like picture. Some, like amiodarone, can cause steatosis. Some will cause cholestasis, like rifampicin, or some can cause sinusoidal obstruction, like syndrome, which is seen post-hematopoietic stem cell transplant. But when we talk about drug-induced liver injury in a patient, the first step is to suspect. Whenever these patients on TB medicine is having an altered liver function, developing jaundice, he's vomiting, we suspect. The next thing we evaluate, which is the possible drug? Is there a dose correctly given? Is there anything else that is going on? Has he taken some alternative medicines? Or is there some concomitant drugs that is causing a drug-drug interaction? Third step is to recognize the pattern of injury, whether it is hepatocellular, cholestatic, or mixed. For this, we use the R score, which I will come in the next slide. Then we exclude all other causes, which is called the causality assessment. This is done by the Rukam score. And finally, we do a severity assessment, and there are multiple ways we can assess the severity of liver injury. So once we have suspected and confirmed that it is a DILI, the R value is a very simple tool. Elevation of ALT or AST above the baseline, we divide it by the elevation of ALP over baseline. If the R value is above 5, it is considered to be a hepatocellular pattern of drug-induced liver injury. If it is less than 2, it is cholestatic, and in between it is possibly a mixed pattern. So once we have done this pattern recognition, the next step is to do the Rukam score, which is a very tedious score for day-to-day practice, but the score ranges from +15 to -3. It has multiple parameters. I'll just tell you what this score means. If it is more than or equal to 8, there is a high likelihood that this is a drug-induced liver injury. Between 6 to 7, we call it probable. 3 to 5 is possible, and if it is less than 2, it is unlikely to be a drug-induced liver injury, and we need to find out other causes. The score basically takes into consideration the latency, what is the effect after you stop the drug, what is the effect after you restart, the risk factors, and then the score is calculated. So once we have done the risk assessment, once we have done the Rukam score, we have to classify the severity of drug-induced liver injury. It can be, there are 2 scoring systems. So we usually use the US DILI network, which can be mild. If the ALT elevation is there, the bilirubin is less than 2.5 and INR is less than 1.5. If bilirubin is more than 2.5, INR is above 1.5, it is moderate. If the patient has been hospitalized for this, it is considered to moderate to severe. And if there is hepatic failure, that is, there is INR is more than 1.5, there is encephalopathy, it is labeled as severe. And finally, the category 5 is fatal. So if we have to properly tell patients of drug-induced liver injury, we have to do all this assessment. So in a patient of ATT-induced hepatitis, we suspect it, we evaluate, we do a pattern recognition, we have ruled out causality assessment, no other causes, and we do a severity assessment. So this is about the etiology of drug-induced liver injury from India. This is a study in 2017 and the previous study in 2010. Both these studies have implicated anti-tubercular therapy as the most common cause of drug-induced liver injury in these patients. And it had a very high amount of mortality in those patients who went into acute liver failure. And even in mortality in children was pretty high. This is another study from a hospital in southern India, where again anti-tubercular therapy was found to be the most common cause of drug-induced liver injury, and similar results have been replicated in other hospitals, and around 30% of these patients were on empirical ATT without any conclusive evidence. So that is something we need to keep in mind. So when somebody starts on an anti-tubercular therapy, some amount of AST, ALT elevation will be there. This is called adaptation. It is seen on around 20% of patients who are on isoniazid therapy. If this adaptation causes an enzyme rise of more than 5 times to fulfill the criteria, we call it drug-induced liver injury. And if this drug injury causes a liver failure, it is acute liver failure. So of these 4 drugs that we commonly use, the most hepatotoxic is considered to be pyrazinamide. So I'll come to one by one. So what is the frequency of drug-induced liver injury? So if isoniazid alone has been used, the adaptation is seen in around 10 to 30% of patients. So some amount of AST, ALT elevation will be there. With rifampicin, there will be adaptation in the form of rise of bilirubin in around 1 to 2%. If you see, if these drugs are used alone, the amount of drug-induced liver injury is not very significant. This is data from anti-tubercular therapy in latent tuberculosis. But the moment you combine rifampicin with isoniazid, or we combine 3 drugs, the amount of hepatotoxicity increases to up to 15%. So we'll discuss the 3 drugs. One is isoniazid toxicity. So we know that isoniazid itself is not very toxic, but when you combine it with rifampicin, the risk increases to 1.6 times. There is no evidence to suggest that giving thrice in a week regimen is better than once a day regimen. And what causes the liver injury is mostly the metabolite of isoniazid. Isoniazid is metabolized by these 2 pathways. We have the one pathway which will form the acetyl isoniazide, and the other pathway which is the hydrolase pathway which will produce acetyl diazide. So most of the isoniazide is usually metabolized by the pathway which involves the N-acetyl hydrolase 2. Now this is a controversy here that some patients will be fast acetylators, some will be slow acetylators. The initial data suggested that people who were fast acetylators can still produce isoniazide toxicity because the pathway goes more towards this side, and this conversion of intermediate products may be harmful. What we have to know is that slow acetylators in multiple studies have shown that their hydrolysis happens more frequently than this pathway, and this intermediate is toxic. Also, it causes more acetylation and causes acetyl hydrazine. So these are all responsible for isoniazide toxicity. Rifampicin again, rifampicin is metabolized by the liver, excreted in the bile. So it causes an activation of CYP34A, and this leads to an increase in the metabolism of isoniazide, and it's yielding more toxic metabolites. It also induces the isoniazide hydrolysis, which I showed in the previous slide, and it also inhibits the bile salt exporter protein, thereby causing conjugated hyperbilirubinemia. Pyrazinamide is a nicotinic acid derivative which is excreted to the kidneys. It exhibits both dose-dependent and idiosyncratic hepatotoxicity. The most toxic level is above 40, which we don't use. The half-life of this drug is significantly longer, around 10 hours, and if you are using it in patients with cirrhosis, the half-life is around 15 hours. So that is why pyrazinamide is to be avoided in patients with cirrhosis. Now, are there any factors other than the drug itself which causes hepatotoxicity? Now, again, this is a controversial part because there are some studies which says that age above 60 and recent studies say age above 35 will have a more incidence of drug-induced liver injury. In people above 60 years where pyrazinamide is used, the risk of pyrazinamide-induced liver injury is 2.6-fold higher. But to counter this, this hepatotoxicity is also seen in 8% of pediatric patients, and in children with tubercular meningitis, around 16 to 39% of patients developed hepatotoxicity, and most commonly it was jaundice. A meta-analysis was done to get rid of this controversy, but it showed that it was higher even in children and compared to adults. So age is possibly a risk factor, but there are contrasting reports. Female has been shown to have a 4-fold risk of ATT-induced hepatitis, and it is also noted that if we have given ATT in a pregnant woman in the 3rd trimester, the increased incidence of hepatotoxicity, particularly with isoniazide, has been noted. In addition, if the patient is malnourished, who has lost significant weight because of tuberculosis, and we are starting ATT, this is an independent risk factor of drug-induced liver injury. And of course, alcohol will induce anti-tubercular drug hepatotoxicity. Also, if the patient has concomitant liver disease, for example, somebody is a hepatitis B carrier, he is not on any treatment till now. So in these patients also, the odds ratio is very high of developing ATT-induced hepatitis. So there is no consensus on whether before starting ATT we treat these patients for hepatitis B. Similarly, patients on hepatitis B treatment also has a higher incidence of drug-induced liver injury. The same goes for hepatitis C. In the study of around 500 patients, 30% patients who were hepatitis C positive had drug-induced liver injury compared to 11% in controls. And the same goes for HIV infections also, where the odds ratio is also pretty high. Now, why does some people develop hepatotoxicity and some people do not? So if you see this, that among the various countries, USA, the hepatotoxicity is around 3%, UK is 1%, Germany 11%, but Japan is 36%. India varies from 8 to 36%. So there is something beyond the drug and beyond the age and alcohol. So there is possibly a role of these genes. There are multiple studies which have been done, and whether it is not only about the acetylator status, it is about the glutathione levels and the glutathione modification, which can possibly increase the risk of ATT-induced hepatitis. But glutathione infusion have not shown to improve the risk of or development of ATT-induced hepatitis. So there's a unifying model that there should be a background genetic predisposition. On top of them, there are some modifiable factors, like the background liver status will determine which patients will develop ATT-induced hepatitis. So if we see that even in acute on chronic liver failure, which is the terminology which is being used for the last 4 to 5 years now quite frequently, 10% of patients, the precipitating factor were drugs, and around 2.5% was due to anti-tubercular therapy. And in acute liver failure, in this cohort of patients, drug-induced liver injury ALF was 14%, and anti-tubercular therapy was implicated in 72% of the cases. And in another study, this ATT alone was implicated in 5%, and some people had viral hepatitis and were on ATT was another cause of acute liver failure in India. So what is important is that we are very scared if the patient develops ATT-induced acute liver failure. So these patients needs to be monitored very frequently. They are usually seen in younger people, mostly women. They have a hyperacute presentation. The median time from development of jaundice to encephalopathy is around 4.5 days, and the median duration of anti-tubercular therapy is around a month. And many patients had encephalopathy and cerebral edema at presentation, and the mortality rate of ATT-ALF was 67.1%. So only 1/3 of them, possibly 32% patients, recovered with medical treatment. And as Dr. VINIT has said, these patients needs an early referral to a transplant center. But if you see a patient who is having a bilirubin of more than 10, prolonged prothrombin time of more than 26, and grade 3 to 4 encephalopathy after starting ATT, these were found to be independent predictors of mortality in this cohort of patients. Now coming to the last few slides, how do we manage ATT-induced hepatitis? The first treatment is definitely discontinue the hepatotoxic drugs. Then we search for an alternative cause, and then once the AST-ALT level comes down to below 2 times of the upper limit of normal, we can restart the anti-tubercular therapy. Now, how do we restart the anti-tubercular therapy is a matter of debate, and there are 2 schools of thought. What is also important is that any ATT prescription should have some printed information to the patient about close monitoring of the liver function test, and they have to be instructed that the moment they have nausea, vomiting, irrespective of whether they have checked their bilirubin or not, they should stop the drug and report to the doctor, and concurrent use of any hepatotoxic drug should be avoided. So how do we reintroduce ATT? So this is the British guideline, which says that you start with isoniazid at 50 milligram per day. Once the AST-ALT has come down to below 2 times of upper limit of normal, then over the next 2 to 3 days, we can keep on increasing by 50 milligram till we reach 300 milligram per day. And then once the LFT is stable, we start adding rifampicin at 75 milligram. Again, increase it sequentially over a period of time, over 3 to 4 days, till we reach the required dose. And then we can add pyrazinamide if the initial drug-induced liver injury was of mild form and reach the desired dose. This is the British guideline, which says you introduce it in this way. Now there's an American guideline which says that once the AST-ALT has reduced to below 2 times of upper limit of normal, we can start rifampicin at full dose with or without ethambutol. And then another 5 to 6 days, we can add isoniazid at full dose, and then add pyrazinamide if the previous hepatotoxicity was mild. Now we are left confused which one to follow. So there has been a comparative study of the British Thoracic Guideline and the American Thoracic Guideline of around 300 patients, and it was found that on reintroduction, the relapse of hepatotoxicity was not statistically significant. It was 9.8% for the British guideline and 11% for the American guideline. And the predictors were people who had high BMI and low albumin, reflecting the nutritional status, were possibly those who had relapse. This is a study from PGI, and Shubhra is with us now in our hospital. So they compared 3 regimen, concomitant, that is all 3 drugs were introduced together, or sequential, that is reintroduction of 1 drug in full dose followed by other, and incremental, that is 1 drug in low dose, and then we sequentially, it is a meta-analysis of 4 randomized controlled trials involving around 577 patients. And it was seen that the concomitant starting had the highest risk, the sequential had the low risk, and the incremental, that is the British one, had the lowest risk of ATT-induced hepatitis. However, it did not matter whether we introduced rifampicin first or isoniazid first. The results were almost the same. So sequential or this incremental benefit had an additional benefit of that we could identify the culprit agents, which drug when you added could cause the ATT-induced hepatitis. We all use N-acetylcysteine, which has been shown to be used for acute liver failure. It is presumed to be effective for any cause of acute liver failure, irrespective of the cause. So this study, however, did not show that it could shorten the ALT at an earlier time, though the length of hospital stay was reduced, possibly the symptoms of hepatitis reduces faster. Now the next 3 slides is on how do we use ATT in a patients of cirrhosis. I will keep this very simple. In patients with child A cirrhosis with a MEL score of below 18, we can use 2 potentially hepatotoxic drugs. However, there will be some child A patients who will be extremely stable. In that case, it has to be customized according to the individual needs. Child B or a MELD of between 18 to 24, it's recommended to use only 1 potentially hepatotoxic drug. And a child score C with a MELD above 25, definitely there is no hepatotoxic drugs should be used. People have compared whether replacing rifampicin with ofloxacin in cirrhosis patient could be less hepatotoxic. The answer was found that 26% who were on rifampicin developed hepatotoxicity, and this was compared to none with ofloxacin. So possibly this is a better option that we can use. Also, there are studies which have listed that patients of advanced chronic liver disease in hepatic encephalopathy, if for some reason we have to use antitubercular therapy, there are multiple regimens proposed out of this. Ethambutol, ofloxacin we know are not hepatotoxic. Cycloserine is also not hepatotoxic. And based on whether the renal function is okay or not, we can decide on adding aminoglycoside or a capreomycin. But my personal experience of using these 2 drugs is close to 0. So this is what my prescription of an antitubercular therapy looks like. This is what I give to my patients. I mentioned it here that there can be drug-induced liver injury. So you need to keep on monitoring, because most of these patients will be going back. So I tell them how to monitor. So we presume that if the ALT, AST is below 3 times, we continue the medications. If it is in between 3 to 5 times, we repeat it at a very early, that is 3 to 4 days. If it is above 5 times, then we definitely stop it. And it also mentions a hepato-friendly regimen, which can be easy for people to follow, because many of these patients are referred from interior places where the regimens are not very clear. So, Chairperson, ladies and gentlemen, to conclude, ATT can cause drug-induced liver injury or hepatitis. Pyrazinamide is the most hepatotoxic drug. Whether we are using it or not, close monitoring of the liver function test is very crucial to identify the patients with drug-induced liver injury very early. We need to rule out other causes of transaminitis in these patients. We have to stop the drug initially and then reintroduce the drug in a sequential manner, which is showing to be safe. If the initial hepatotoxicity was moderate to severe, we do not reintroduce pyrazinamide. And in patients with cirrhosis, we use ATT in a very cautious way with no hepatotoxic drug in child C, 1 drug in child B, and 2 hepatotoxic drug in child A cirrhosis. With this, I thank you all. Thank everyone for under the invitation. We are having the endoscopic biggest conference from 8th to 10th of September for any gastroenterologist here. And anybody who is interested, it's an invitation to AIG Hyderabad. Thank you so much.
Hello.
So if the patient was started on ATT for, this is in Western countries, if it is started for latent tuberculosis, the guidelines say you don't even have to see the baseline LFT. But on patients on antitubercular therapy for a tuberculosis that is not latent tuberculosis, we advise it to be monitored every 7 to 14 days initially. And if there is symptoms like nausea, vomiting, even if he was tested 3 days back, he has to retest his liver function test. ALT is more sensitive than AST, and bilirubin is for rifampicin mostly. Yes, sir.
This is a very nice coverage. So I have one question. If patient is having fulminant tuberculosis or miliary tuberculosis, sometimes we have to add steroids also. In that circumstances, if we have patient develops hepatotoxic drugs, which drugs we can give safely? Can we get idea? Whether you have already mentioned that rifampicin get cholestatic, isonics get hepatocellular necrosis. So shall we get idea that we can withdraw this drug first and then we can give a good drugs for that?
So we have this problem with miliary tuberculosis, meningeal tuberculosis, and patients with genitourinary tuberculosis. In these patients, we cannot stop the antitubercular therapy. So we usually advise to give ethambutol, a fluoroquinolone, either a levofloxacin or a ofloxacin. If the renal parameter is preserved, we give streptomycin because we need one drug which is bactericidal. All the other 2 drugs are bacteriostatic. And then one of the second line drugs is to be added. But we don't stop the medications in that cohort of patients because that is one indication where the antitubercular therapy needs to be continued, and we use all hepato-friendly drug and streptomycin. Once the AST-ALT comes down, we try to reintroduce either rifampicin or isoniazid, because majority of the time the toxicity is because of the combination of INH and rifampicin. So using one drug may not cause drug-induced liver injury. If it happens, unfortunately, then we are left with only those 4 drugs.
And, if someone has delay with anti-tuberculosis treatment, and if we have reintroduced after enzymes are normal or it has come down below 2 times of the normal range, and if they again develop delay, then what should we do? We can so again restart, or we have to stop forever?
Yeah, no. So if they again develop hepatotoxicity after it has come down to 2 times of normal, then the sequential mode of therapy identifies which drug is causing. For example, we added isoniazid, the LFT was perfect. The moment I added rifampicin, then the toxicity started. So we have to understand that this is a combination toxicity. So then rifampicin cannot be reintroduced. We have to go to other line of drugs.
Should we consider sequential and incremental introduction of ATT in the subgroup of patients which have been treated for tuberculosis, suffered DILI, and recovered? Now they are again needed to start with ATT, maybe defaulter or maybe reinfection.
So we normally, in our center, we normally go for incremental treatment, because that is how I can identify the drug that I need not be used. We have never introduced the American way where all the drugs at the full strength are used after a drug-induced liver injury has happened.
Any question or any more comments from the chairs?
In our area, that is in our area, most of the people are undernourished, malnourished, and on and about they develop tuberculosis, we start AKT, and on and about they might be taking some alcohol also. So what is your consideration? According to body weight, we usually try to give them medicines, but sometimes with slightest medicine, they are prone to develop hepatotoxicity.
So nutrition, so normally we say we have to give them around 30 to 35 kilocalorie of nutrition per day. If they are totally malnourished and not able to tolerate antitubercular therapy, at our center we are tube feed them. We admit them for at least 2 to 3 weeks, or send them home with a Riles tube and feed them with this. But because nutrition has to go, because I understand this is a very common problem. They say I am feeling nauseated because of the drugs, so I cannot eat anymore. So, but the only way we can tackle this is by improving the nutrition. And we cannot wait till I build up the nutrition and start antitubercular therapy. It may be too late. So it has to go parallelly both. And the only way is if he is not tolerating orally or not able to take the required amount of protein intake and the calories, It has to be an enteral feeding in hospital and then continue with anti-tubercular therapy.
What is your concept to prescribe, co-prescribe hepatoprotective drugs along with AKT?
So there are no literature to suggest that either ursodeoxycholic acid, S-adenosylmethionine, or glutathione can protect against development of drug-induced liver injury. Let us be very clear, ursodeoxycholic, the only indication which is established is primary biliary cirrhosis or cholangitis. All other, it can normalize ALT, but there is no evidence to suggest that this will help. It will only increase the burden of cost to the patient, but doesn't help at all.
Last question, I think, can it make any difference if we give anti-tuberculosis drug at different time of the day rather than giving simultaneously at the same time?
I didn't get the first part.
Does it make any difference if we give anti-tuberculosis drug at different time?
Separately? You are meaning morning and evening. Morning and evening. I searched actually for that, but there is no data, but rifampicin needs to be given in empty stomach. The other things the patient can take after food. So that's how we tell them also, that before the breakfast you can take the... I never prescribed Acute 4 or AKT3. I am not a firm believer of combination. It's basically, it has to be individual drugs so that we can titrate the dose. So we should do away with this 4 drugs and we don't know what is going on. So it's better to divide it, then whatever you are saying, we can implement. That rifampicin can be taken in the morning and after 2-3 hours after lunch you can take the others. But there's no evidence to say that that will cause less of hepatotoxicity, though the tolerance may increase. That's the only thing.
Thank you, sir.
Yeah. Thank you so much.
Thank you very much, Dr. Mithun Sharma, for the excellently elaboration on this complex topic like delay. And thank you all the chairs for your valuable time. I would request Dr. Naresh Ghabani to please felicitate Dr. Mithun Sharma. Dr. Naresh Ghabani, sir. Thank you, Dr. Mithun. Thank you all the chairs. We are approaching the end of this knowledge feast, so I would request Secretary, Association of Physicians, Surat, Dr. Tarun Chawda, to please deliver the vote of thanks. Dr. Tarun Chawda, Secretary, Association of Physicians, Surat.
Hello. Good noon all. I thanks all the speakers for sparing their valuable times and sharing their knowledge to enlighten our knowledge and travel so far. I thank you. I also thank Dr. SAUMIN and Gujarat Gastro Hospital and the whole team to arranging this CME. And I thanks all the delegates to come and make this CME successful. Our next CME is on 26 June on cardiology, and I invite all to participate in the CME. Now I invite all to join for a lunch. Thank you.
I would request Naresh Ghabani sir to give the concluding remarks, and please, I would request Dr. SAUMIN sir to please give memento to the chairs.
Good afternoon. Good noon, everybody. On behalf of team Gujarat Gastro Hospital, we thank you all for your gracious presence on this occasion. We also thank our speakers, those who have been here physically and those who have been online. Dear friends, this was a very excellent academic fest, and we hope we will continue to work together in terms of academics as well as clinical work for the patient. I thank you all again by heart from the team Gujarat Gastro Hospital. Thanks a lot. Thank you.
પૂછી લો પહેલા સરને. ચેર્સ કયા છે? લાવો ચેર્સ.